We are going to talk about spinal cord today. So it is October 21st, 2020. Yeah, feedback, exactly. And we're going to talk about spinal cord injuries. So the first thing I'm going to bring up is going to be terrifying to you. Do you guys remember this from anatomy? Oh, yeah, right? So I get the question oftentimes is, do we have to know these? Yes and no. I'm going to teach you kind of what you need to know about these when we go through spinal cord injuries. But what's really easy to remember, though, you have to remember, right, that efferent is motor, afferent sensory, right? You guys remember that from anatomy. That's important because there'll be a lot of times where the boards will talk to you guys about efferent tracts, and you have to be aware in your head that, oh, they're talking about the motor tracts. If you don't remember that, that can be problematic. Yes, that's the next thing I was going to say, is the tracts are labeled for where they start and where they end. So if it is a cortico-spinal tract, it starts at the cortical portion of the brain and goes to the spine. If it is a spinothalamic tract, it goes from the spine and goes to the thalamus. Does that make sense? That's kind of how they're labeled. So you have ascending, which would be your motor or your sensory tracts. And then you have your descending, which are your motor. Because obviously ascending are going to send up to the brain. Descending are going to send down from the brain to the body. I remember now. Pepperidge Farm members. If you look at most of them kind of tell you what they're responsible for. Most of your sensory stuff that you're going to deal with. So when we talk about, loss of pain, loss of stuff like that, most of your sensory group is grouped back here in these dorsal columns. Right? So the posterior aspect of your spine has a lot of your sensory information. Now, obviously, you have the spinothalamics, which also have something to do with pain and touch and stuff like that, which we'll talk about as we go through this lecture. But things like the spinal olivary and the olivary spinal, you're not going to have to split those up pretty much, right? Vestibulospinal, definitely one you're going to have to know, because what is vestibulospinal going to help with? Balance, right? And more importantly than balance, we don't think about a lot of this, but posture, right? Your vestibulospinal tract is going to be the tract that tells your body how your posture is. So that's kind of what that one's primarily used for, right? And I know that it shows as red. That's going to be one of those weird tracts. And they don't talk about this a lot, but the vestibulospinal tract has a little bit of a sensory component too. So it sends some information back up to the vestibular system. But you have to know that it's a primary motor tract. Most of the sensory ones are pretty easy, like spinocerebellar, spinothalamic. It kind of tells you where they're going. You don't have to know the difference in the dorsal columns. You don't have to know the difference between the gracilis and the cunate fasciculus, stuff like that. You just have to know the dorsal columns. So again, don't totally spaz out about it. Why is it important to know all these tracts and where they are? Well, it's important because when we talk about spinal cord injuries, if I get an injury to the posterior portion of my spine, patient's going to react a certain way. If I get an injury to a lateral compartment of my spine, patient's going to act a different way. If I get an injury to the anterior compartment of my spine, patient's going to act different. That's why these are important, because these will tell us what the patient's typically going to look like. Now, again, when I talked about strokes, I talked about no patient kind of presents the same. It's sort of the same here with spinal cord injuries, but not quite. Spinal cord injuries have some pretty hard rules on what a patient's going to present like. If you have a patient's got a posterior aspect injury, they're going to have a lot of sensory loss. And so that's going to be kind of problematic. With the spinal cord also, you're going to have that weird issue where certain spinal cord injuries will have ipsilateral problems, right? Same side problems. And other spinal cord injuries will have contralateral problems, other side problems, right? So I used to make you guys do a homework where you had to draw and color all this. I would recommend before you go get ready for your boards, maybe to print this slide. I think I have a better picture of it up in the spinal cord folder. But this would be something to kind of keep when you're getting ready to study for the boards, just so you can remember kind of where they're at. So some incidents of spinal cord injuries, approximately 17,000 new cases in the year in the US. Gross cases show that there's between 200 and 350, 400,000 injuries with spinal cord in the United States. We do have this thing called the NSCID, which is the National Spinal Cord Injury Database. It was established in 1973. And this is the geekiness in Mr. McKeever. If I had a choice to go to two places for vacation, so I can kind of, I really want to go to Rancho Los Amigos. I really want to go to their study center. And I also want to go to University of Alabama at Birmingham, UAB, because that's where the NSCISC is, the National Spinal Cord Injury Statistical Center. Yes, I want to take nerd vacations is what I'm saying. But they're established to kind of track spinal cord injuries because we saw that it's pretty big. Interesting thing here, it shows 4-to-1 ratio, men to women. So about 80% of spinal cord injuries are men. Good job, guys. And about 51% of them are between the ages of 16 and 33, right? The hold my beer age, you're exactly right. And there is a mean age of 42, but that's also because we have to give these two peaks. We have the peak in the early years, and then we have a peak in the later years where we start getting the dysfunction of the spine, where our spine gets osteoporotic and stuff like that. That's what I was trying to say. Ethnic breakdown, non-Hispanic Caucasians are about 60% of all spinal cord injuries. Non-Hispanic African Americans, about 22%. Hispanic origins, 11%. Others, about 3.5%. So unfortunately, that's just the way it is. If you're male and Caucasian, you're in the primo category for getting a spinal cord injury. 50% of all spinal cord injuries are cervical in nature. That makes sense. Where do you think most of those cervical injuries are going to come from? Car accidents, exactly, Scano, right? Car accidents are the major thing. Thoracic's about 35%, lumbar's about 10%, sacral's about 0.4%. Why do you think it gets less and less the further down the spine you move? More protected, right? And they're stronger, bigger vertebrae, exactly, right? So the further you go down, the bigger the vertebrae start becoming, and the more protected around the area, right? You start having more muscles. Think about your neck. You have a good bit of muscles up here, but when you get down to like your lumbar region, man, you've got a lot of tissue around that lumbar region to absorb some of that shock, right? Your neck's a lot more mobile, which is going to lead to more injuries. So motor vehicle accidents, motorcycle accidents lead to about 40%, 38%. And again, you're not going to have to know these percentages, but it's kind of important to understand this. 30% come from falls. Makes sense. 13% comes from acts of violence, 9% from sports injuries, and another 9% for unknown etiology, which is kind of like the garbage can collect all for the rest. The interesting fact about this is spinal cord injuries from sports are actually on the rise. Why do you think spinal cord injuries from sports might be on the rise? Any ideas? Okay, Royce may plan to play, right? Renee says, Royce is fantastic. What it is our athletes are becoming more freakish kind of specimens of nature, if you look at it, right? I always think back to when I played football and you had those big guys. Again, I talked about this with concussion. You had big guys, but they weren't fast. They were just big and strong. Now those same 315-pound big guys can now run 4.740s, and they turn into basically tanks, or better yet, tractor trailer trucks, right? So we're getting, you know, as sports improve, you would think that also our safety improves, but it doesn't. We don't take this into account, and people end up injured for life. So here's good old Christopher Reeve, right? At 6'4", Christopher Reeve was cast to play as Superman. Film gross, look at this, $300 million in 1978. Do you know how crazy of a number that is? That's literally almost super. In May 1995, Christopher Reeve became quadriplegic after being thrown from a horse. So we're going to talk about this, but what does quadraplegic mean? Yeah, exactly. Erica's a fantastic comment. She always liked the fact that he based Clark Kent after Cary Grant. That's exactly what he did. And he made Clark Kent fun. He was kind of a goofy guy, just like in the comic. That's beside the point. So what does quadriplegic mean? Yeah, he lost the use of all 4 limbs, right? We're going to talk about quadra versus tetraplegic a little bit later here, but so he lost all use of all 4 of his limbs. It's interesting. Right after his injury, he actually asked to be euthanized. Superman asked to be killed. That's like, I just can't imagine what would put you in that mindset. His wife, because, and the reason for it was he didn't want to be killed because of his injury. He wanted to be killed because he didn't want to put his wife through taking care of him. That was why he asked to be killed. And his wife, you know, contrary to all of our, it does make it so sad, doesn't it? Right? His wife specifically said, no, I am not leaving you no matter what. And she didn't. She stayed with him all the way through the end. Right? When she did that, that changed his mind. And he started becoming an advocate for spinal cord injury patients. And he was a tremendous advocate for spinal cord injury patients. Right? But if you look at it 10 years later, he developed a sacral pressure ulcer that led to sepsis. And then, you know, so October, I think it was October 2nd, they found the ulcer. October 9th, he received an antibiotic for the septics, which led to cardiac arrest. He was dead at 52. And that's if you get an early enough spinal cord injury, that's a good life. The major thing he pushed for here is stem cell research. And he founded at UC Irvine, the Reeve Irvine Research Center. And they're looking at how can we use stem cell implants to improve the overall function of somebody that has spinal cord injury. You know, we're not at the point now where we can inject stem cells and the spine regrows, right? But we're going to talk about having areas of partial preservation and stuff like that. But what if we could inject, maybe, you know, you lose your legs, but what if we could inject stem cells just above it and you get some of your trunk control back? That would be huge, right? Just even getting something as little as that can make a huge difference. And this is where Mr. McKeever makes the insensitive comment of the day. So please do not take this wrongly. This is just a joke. I want to specify. This is just a joke. Do you understand that, Erica? This is just a joke. I want to see if she responds. What is the difference? What is the opposite of Christopher Reeve? Christopher Walken. That is just a joke. That is just a joke. Do not take it for, yeah. That's a Mr. McKeever special one. I told that my first time I was teaching here, and man, I got, like, Dr. Shima called, she goes, so I heard you told an insensitive joke in the class. I'm like, it was just a joke. Come on. All right. So mechanisms of injury. How does it happen? The most common is a flexion injury. Why do you think the most common is going to be a flexion injury? Well, think about it. Right? That's where we spend most of our day, is flexed forward. We don't do a lot of stuff going back that way. Right? Posture, exactly. The second most, we have some hyperextension, we have some compression. Flexion with rotation will cause the greatest damage, right? Which is why we're taught, if you have to pick things up with your legs. If you can't pick things up with your legs, try not to pick them up. If you do have to pick them up and you can't use your legs and you have to use your back, don't twist while picking things up, right? Those are all really good kind of guidelines to save your back. Shearing also occurs where the bones kind of shear over each other. Distraction is the least common, right? And we learned about this. I hope you learned about this when Dr. O'Neill talked about traction. Did she talk about how much force is required to pull apart the spine? When she talked about traction in modalities? Like, to get separation, it's about 10% of your body weight, right? 10 to 25% of your body weight to get it pulled apart. To actually physically pull apart, to physically pull apart the spine and cause damage, it's around 375 to 400 pounds of force. We are never gonna, get the horses, exactly. We're never gonna do that in real life in traction, right? The most I've seen somebody go on traction for is about 200 pounds, and that was me. Because I wanted to test 85% of body weight. And so I put myself on that to see what it would feel like, because that's kind of the max we want to do with traction. And man, that felt weird. Afterwards, it wasn't the traction on it. The traction on it felt really good. And then I got up and everything kind of settled and it just felt so weird. Like I kind of felt wobbly. So it's really rare that we're going to pull the spine apart. The only time that we encounter really spine pulling apart is, again, like Erica said, back when we did draw and quartering, right? And at the point that we pulled the people apart, the spinal cord injury was usually the last thing they were worried about, because they usually lost their arms and legs too. Any of the forces above will either result in a fracture or dislocation. The highest frequency of injuries are C5 to C7 and T12 to L5. So when we talk about spinal cord injuries, when you're looking at them in the hospital, they're going to be listed as either a traumatic spinal cord injury or a non-traumatic. Traumatics are usually the most common. Those are motor vehicle accidents, motorcycle accidents, slips and falls, right? Call Glenn Lerner today, 877-1500 or whatever. Violence, sports related, and then surgical metal. We actually do cause problems in physical therapy and other things that can cause traumatic spinal cord injury patients. Non-traumatic, degeneration of the spinal cord, infections, right? Specifically pathological organisms. So stuff like meningitis and stuff like that can affect our spine. Cancers and tumors. Inflammation. This is typically a chronic breakdown of the spine, right? RA, DJD, DDD, right? What is the difference between DJD and DDD? First, I have to remember what those are. DJD, what is DJD? J is joint, right? What's the D? Versus the disc. Good, right? Now, here's the interesting thing. Degenerative joint disease can cause degenerative disc disease. Degenerative disc disease can cause degenerative joint disease, because in the spine, they're so closely played together that if one of them starts breaking down, the other one can break down too, right? So like if your disc starts breaking down, that's going to put more of that force onto the joint itself, which then is going to cause that to break down. If your joints break down in the spine, then that's going to put more of the force on the discs, which means the discs are going to break down. So that's kind of one of those darned if you do, darned if you don't scenarios, right? Vertebral subluxations, where the vertebrae just kind of slide, is common. Congenital medical issues are common, especially this term called hemangioma. So hemangioma is where if we have that kind of, here's our spinal cord disc and we have our bone kind of overlaid over it, right? That's a really bad drawing. That is a really bad drawing, Mr. McKeever. A hemangioma is where blood vessels come in and start growing into the vertebral body, right? I tried to find, I had my, I can't figure out where my MRI is. I have hemangioma at T10, where the blood vessels have grown into the body of T10 for me. Now, the good news is it's asymptomatic. I don't have any problems from it. And it just is one of those, most times when you have hemangioma, they just monitor it. They're just making sure that it doesn't get any greater. Because think about it, if the vertebral body has blood vessels growing into it, that means that that's no longer as patent or as strong as it should be, right? That's where all that compressive force is going in. So that just leads that vertebrae to be a little bit weaker. So later on in life, when I'm older, especially when I start developing osteoporosis, that's a potential area of injury for me, right? Because that disc or that vertebral body is just not as strong. So it's a potential chance for me to get a compression spinal cord injury when I sit down or do something like that. So I've got to watch my hold my beer moments when I get older is what I'm saying. So when we talk about spinal cord injuries then, so once we have trauma versus non-trauma, the next thing we're going to talk about is whether they're tetraplegic or paraplegic. Now, oftentimes we will use quadriplegic and tetraplegic kind of interchangeably. Tetraplegic, or let's go quadriplegic, means all 4 limbs are affected. Tetra is now 5. What do you think the 5th thing they're talking about would be affected? Well, the trunk. That's your 5th limb. Does that make sense? Because if I can't use my arms, all these muscles are going to be locked out too. But we do have some weird cases where people will be quadriplegic. They'll have loss of use of the arms and legs, but they'll have trunk control. Right? And that could be, honestly, that's possibly the best case scenario if you're going to have a spinal cord injury and it's going to be that bad, is at least to have trunk control. So it's typically cervical cord lesions that are going to be tetraplegic, complete paralysis of all 4 extremities and trunk, and potentially including respiratory muscles. Do you guys remember the mnemonic I taught you guys way back when about spinal cord injuries in order to know where the injury needs to be below in order to have normal breathing? What is it? C4 or breathe no more. Right? C4 or breathe no more. So anything below that on the spinal cord injury, the patient's normally going to have normalized breathing. If you get up into the C3, C2, C1 region, you're knocking out the muscles of respiration. And at that point, the patient is going to have a bad outcome, right? Because they're no longer going to be able to breathe necessarily on their own. So C4 or breathe no more is an important thing to remember. Paraplegic. This is usually thoracic, lumbar, or sacral cord lesions. It usually means they lost their legs, right? They may have part of the trunk as well, but the main thing is their legs. So just remember that we have 31 pairs of spinal cord nerves, 8, 12, 5, 5, 1, and that the difference is C1 through 7, the nerve roots exit above. That's why we have that C8, and then we get the nerve roots exit below in the following ones. So some clinical pearls to remember about spinal cord injuries. And this would be one that you may want to star because the boards love asking questions about this type of slide. The vertebral column is longer than the spinal cord. So the actual bones of the spine are longer than the actual spinal cord itself. The fetal cord, right? So when you're a baby, is equal in length to the vertebral column, but as your column increases in length, the nerve roots progressively become more oblique as they exit the column, so it becomes a little shorter. The cervical nerve roots exit nearly horizontally. So when the cervical nerve roots come out, they come almost out like this. When you get down to the lumbar, they're almost vertical. The conus medullaris, this is an anatomy term. It is the point of termination of the spinal cord. So the spinal cord itself ends at about L1, L2. After L1, L2, it becomes the cauda equina, and that means horse's tail, right? It's a name for the nerve roots that exit below the conus medullaris. And the reason it's called the cauda equina is if you look at it, it kind of becomes very stringy and looks like a horse's tail when you draw it out. The filum terminale, or terminal thread, is a delicate strand of fibrous tissue. It's about 20 centimeters that proceeds from the apex of the conus medullaris and tethers the spinal cord, right? So you have the filum terminale internum, which is the conus medullaris to S2, and the filum terminale externum, which is the apex of the tubular sheath, the first segment of the cog6. The interesting thing about this to remember is the FT, or the filum terminale, is the continuation of the pia mater all the way up to the brain. So the pia mater starts up here in the brain and goes all the way down your whole spine until it anchors the spine down at the sacrum. So that's a pretty important kind of thought process, because when you think about it, if I get a pull or a torsion injury on that filum terminale, that theoretically could even cause some brain injury, right? Because it's contiguous with the brain. So again, a lot of terminology here, but good things to remember. Hint, hint, nudge, nudge. Bob is your uncle. Oh God, do we remember this one? I hate this one, Mr. McKeever. Yeah, I know you do. Too bad. This is looking at the nerves, right? So we have our backside, our posterior aspect, and we have our anterior aspect, right? Remember when you're looking at questions that posterior and dorsal are the same and that anterior and ventral are the same. Don't let those catch you up. Posterior is primarily sensory nerves. Anterior is primarily then motor. Good, right? Now the motor neurons usually break up between the somatic neuron and the visceral neuron. You don't necessarily have to know that they separate out. That's not really as important as everything else, right? The thing you do have to remember, though, is the horn cells, right? So our horns form the horns on the spinal cord. So here we have our anterior horn, and here we have our posterior horn. The anterior horn is motor horn. The posterior horn is sensory horn. The sensory nerves also have this thing called the dorsal root ganglion. And that dorsal root ganglion, my cousins. Oh, I get it. Yeah, okay. Good job, AJ. You got me there. I didn't think about that. Your cousins. I get it now. The dorsal root ganglion is where a lot of those interneurons play. That was fantastic. It just took me a little bit. I'm not the most awake in the world here. There's a lot of interneurons here that kind of link up, right? And you got to remember, with sensory nerves, right, when all this sensory information comes back, when it hits here at that posterior horn, the posterior horn has to decide, is this information the brain needs to receive, or is this information the brain doesn't need to receive? Your reflexes, for example, right? If when you tap on your arm and you get the bicep reflex, right? And I'm actually doing that. That's not actually happening. That sensory, when I tap, that sensory sensation goes up that nerve, goes all the way back to the spine. The spine says, this doesn't need to go to the brain. I can react on this, sends the signal out the motor neuron and causes that contraction. So that is a spinal cord mitigated reflex versus something where you touch a hot pan. That is going to be a central nervous system regulated reflex because the brain has to think about it. Spinal cord related reflexes or spinal cord mitigated reflexes are always going to be faster just because there's not any cortical processing. The brain doesn't have to think about it. So the reason I cover this is because now we need to get into this. Remember, I talked about this before. We get into this upper motor neuron versus lower motor neuron. If you're a note card creator, I would create 2 note cards for this, one for upper motor neuron, one for lower motor neuron. The boards love to ask questions on these because it's really, really simple to write questions on these. So your upper motor neurons occur above or before the level of the anterior horn cell. So remember, we're only talking about the motor stuff now, right? So an upper motor neuron will occur here all the way up to the brain. So before that anterior horn cell. So upper motor neuron injuries are more CNS related injuries, right? Does that make sense to everyone? Because here's the horn cell. This is still part of the CNS, right? But definitely anything before that is CNS related. So upper motor neuron injuries are more CNS related. Lower motor neuron are usually more PNS related. So upper motor neuron before the anterior horn cell. This is what you're going to have. You're going to have a hyperreflexic patient. So they're going to have hyperactive reflexes, meaning your DTRs are going to become very kind of spastic looking. The patient is going to have a positive Babinski sign. So you're going to touch the toe, touch the bottom of the foot, and what's going to happen to the toes? Do you remember what a positive Babinski happens in an adult? Yeah, they kind of splay out and fan out, right? So that is a sign of a upper motor neuron injury, right? And even if you have that, it's possible you've been walking around with an upper motor neuron injury for years and didn't know it. Just because you have an upper motor neuron injury doesn't mean you're non-functional. It just means you might have somewhere in that, you know, from the spinal cord up that has some sort of damage, right? They will typically also present with clonus. Remember, clonus is where we do some sort of motion and they beat, right? And they just sit there and kind of wave bye-bye to you. It could be the bicep, same thing. You pull up on that and it just kind of beats. I've had, you know, the worst clonus I saw is I actually had a patient that had really bad clonus of the neck. And so anytime you would stretch him, after you stretched him, he kind of looked at like Night of the Roxbury for a while. He just sat there and did that back and forth. And it was really uncomfortable for him. You got to think about it. That's probably going to be really uncomfortable if you're constantly shaking after getting a good stretch going on. The upper motor neuron injury is going to cause disuse muscle atrophy. Because there is no signal going to the muscle is just going to waste away. Right? So the muscles will eventually waste away. So that means later on, if you have an upper motor neuron injury, is clonus going to go away? Or become less relevant? What do you think? Let's say 15 years from now, in your spinal cord injury, your muscles are now wasted, you're less likely to have clonus, right? Because the muscles aren't there. They can't trigger anymore. They're gone. And these people, when they have real bad spinal cord injuries, if you ever saw them, their muscles just are gone. They're pretty much skin and bone in the area where they have no function, right? Fasciculations, fibrillations are absent, meaning you don't get those little quivers in the muscle themselves. Well, that makes sense. Quivers are caused by nerves, right? So, you know, you're not going to get those little eye twitch. Well, if you have spinal cord injuries, you're going to have an eye twitch. But think of fasciculations or fibrillations, kind of that eye twitch thing idea, right? Do you ever get there, you're sitting there and all of a sudden you get that kind of, I don't want to call it spasm, but where your quad's like kind of doing one of these numbers, and then it stops? That's a fibrillation. Right? And you're like, you rub it out and it goes away. With upper motor neuron injury, where that nerve is not going to the muscle, you're not going to ever get those. They will become hypertonic, leading to spasticity. And that spasticity is velocity dependent. What would velocity dependent spasticity mean? So spasticity means I'm tightening up like this. Yes. So let's say I'm spastic and I'm up like this, and you pull to stretch me out. If you pull me nice and slow and even, I'm going to be less spastic. If you start pulling on me pretty quick, it's going to increase my spasticity. Right? So this is why we learned all the time, if you're going to do stretching with the patient, low and slow is always the better way to go. Right? Especially with the spinal cord injury patient, because that way you don't trigger their spasticity. And they're going to have loss of autonomic control. So in that area below the injury, they're going to have a loss of autonomic control, whatever it is. It can be something like bladder. It could be digestion, right? So they're going to have loss of autonomic control with an upper motor neuron injury. Now, lower motor neuron injury, again, going back to this beautiful picture, lower motor neuron injuries occur at, so either here or after the anterior horn cell. So I'm going to use myself as an example here. Initially, when I had my spinal cord injury, right? So here's my vertebrae laying over it, right? This whole side of my left side was compressed. So I had lost both sensory and motor, but the compression occurred out here. So because it occurred out there, it meant that my motor injury was a lower motor neuron injury. Does that make sense? Because it didn't happen back here at the spine or in the brain. So what did I look like with a lower motor neuron injury? That's a great question. We're going to talk about that. A lower motor neuron injury is going to present with hyporeflexia or hyporeactive reflexes, meaning they're either going to be so small that you're not going to notice it, or there's going to be none at all. And they're going to have an absent Babinski sign. That is different than a negative Babinski sign, right? So if you are testing for Babinski, what does a negative sign look like with an adult? What do they do? So you know that positive is flaying of the toes. Giggle maybe, okay, yeah. The toes kind of like curl a little bit. You kind of curl, yeah, you kind of avoid that. You pull that foot away because it doesn't feel good. It tickles, right? Well, with a patient that's got a lower motor neuron injury, they're not going to do anything. They're just going to sit there. You're doing what? Right? And oftentimes they lose that tickle factor too. They will eventually end up with neurogenic muscle atrophy, which is severe wasting. So when we go back here to upper motor neuron injuries, disuse meaning the muscles will waste away because they're not getting used. With neurogenic muscle atrophy, they're getting a weird absent signal. So the nerves are being sent out to the anterior horn cell, but then the phone call is not connecting. And so oftentimes if you have a lower motor neuron injury, the muscles waste quickly. You know, and I looked last night, the studies say anywhere to 5 to 7 times what a normal wasting would occur. So, you know, and I noticed that, especially in my hand, when I had my injury, I watched almost my thenar eminence and my hypothenar eminence just waste away in a couple weeks. You get rapid, severe wasting. You will get fibrillations and fasciculations, or could get, I guess I should say, but you will get them frequently. And what that is that's that residual signal kind of creeping out there and causing the muscle to twitch, right? It's like, and then it stops. They're not actively doing anything. That just means for whatever reason the signal's getting there, but it's not a complete signal. They will become hypotonic to flaccidity, and usually will lead to flaccid paralysis. So if you've got a lower motor neuron injury, this is what happened to me. Within a couple weeks, actually it was about 2 weeks, this whole left arm of mine was just loosey-goosey spaghetti noodle. I couldn't get it to do much. I had finger motion. That was about it. So I could grab things. I could still play video games, but really poorly. And it was ironic. I used video games a lot for my rehab. I kept telling myself that was why I was playing Call of Duty. Sure it was. But this arm had just completely gone dead until I had surgery. So here's looking at all those spinal cord stuff again. Just remember kind of where they're at. I have a great sheet I'm going to give you that kind of helps you break down if you get the injury at C4, what muscles are you're gonna have. If you get an injury at C5, what muscles are you going to have? Because that's going to be a lot of questions on your boards with spinal cord injuries. Your board questions are going to be a lot of, your patient has a C7 spinal cord injury. And I'll say, which of the following exercises are appropriate to do with the patient, right? And you have to know that if they're C7, that means they have C5, C6, C7. So you may be able to do bicep curls, but you're not going to be able to do something like with the lats. The lats are gone. That's how the questions on your boards are going to be kind of worded. All right, so here is the ASIA assessment. No, Asians didn't develop this. This is the American Spinal Cord Injury Association assessment of patients with spinal cords, okay? American Spinal Cord Injury. So this is the test. This patient has a spinal cord injury. This is the test we're going to do on them to tell what is functional. And if you notice, we're going to test left and right sides. So as we go down, we're going to test C2, C3, C4, C5, C6, all the way down until we get down here to S4, S5, right? Now, who's going to do this test? Initially, this test is going to be performed by a spinal cord injury doctor. He's going to kind of give us the baseline. And then they're going to come to PT, and we're going to do an ASIA assessment on them because we need to know as well. And we need to see if there's any change from baseline. What this gives us is a lower extremity motor scale, an upper extremity motor scale that tells us, you know, how hard is this patient going to be to rehab? Because if I'm missing a ton of my motor function, I'm going to be a difficult patient, right? If I don't have upper and lower extremity motor function, I've got to start thinking about some care for this patient. But maybe if the only thing I lost is L4, L5, maybe it's not as bad. So we're going to talk about a couple things. So the ASIA assessment is used to create by the, all that word, right? It's used to assess and provide a standardized examination method to determine the extent of motor and sensory loss. When we are talking about spinal cord injury, again, we're going to talk whether they're traumatic or non-traumatic. The next thing you're going to see is the injury level, also known as the insult level. And then you're going to have a neurological level. The injury level is where the injury happened. That's why it's called the injury level. I know, it's pretty amazing that they name it that way, right? The injury level is where that spinal cord, that first neurological deficit occurred, right? So let's say I get stabbed and it says that T4 is my injury level. What that means is when that person stabbed me in my spine, that knife impacted T4. Does that make sense? Are we okay on that part of it at least? Okay, good. Because the next one is the important one. The injury level is great to know. That's not important to us, really. I don't ever care about the injury level. That's kind of one of those, oh, that's nice to know. I need to know the neurological level. The neurological level is the most caudal level, so the furthest down of the spinal cord with normal motor and sensory function on both sides. The most caudal level of the spinal cord with normal motor and sensory function on both sides. So let's go back to my example. I'm walking down on the strip and some thief comes up behind me and stabs me at T4. Right, so now T4 is where my injury occurred. What do you think the best case scenario for a neurological level would be for me? The best case scenario. It's usually one level above where the injury occurs. So T3 would be the best case. So what that says is T4 is where the injury happened. I'm going to lose something there. But maybe I have full function at T3. Most of the time, that is a pipe dream. Because most of the times your neurological level is going to be 3 to 4 levels above where the injury happened. So if I'm a T4, it's more likely I'm going to be a T1 to a T2 neurological level. That doesn't mean I don't have any function at T3 and T4. What it means is let's say I'm a T2 neurological level. That means at T2, everything is normal. Everything below that T2 has got something knocked out. Maybe I've got sensory knocked out at T4. I've got some motor knocked out at T3. You get up to T2, I've got both sides functional, both motor and sensory. Does that make sense? So let's go down. Let's say now I'm in a car accident where I get a crush injury to L4. What is my best case scenario neurological level if I'm an L4 patient? L3 would be the best case, right? What do you think is going to be the most logical? Where do you think I'm probably going to be? For a neurological level. It's okay to guess. Hopefully I'm L2, right? Most times I've seen it at the L. It's usually it'll go. If it's like L4, it'll be T12. Because don't forget, at the L's you start getting into that sacral plexus, or not sacral plexus, the lumboplexus, right? Lumbar pelvic plexus. And so those nerves are so intertwined. A lot of times I don't get full normal until I get up to T12, which is kind of sad, right? So now we have traumatic versus non-traumatic. Now we have an injury level and an injury or insult level and a neurological level. Then we need to determine whether they are a complete or incomplete spinal cord injury. So a complete spinal cord injury is no sensory or motor function at the lowest sacral segments, meaning you have no function at S4, S5. How do we test for that? We have two different tests we can do. We have the ASR, not to be confused with the ASMR. The ASR is the anal sphincter reflex, or the anal wink test is the other term it's called, or the perineal reflex test. This is tested by stimulating the skin and tissue surrounding the anal sphincter by stroking the skin to see if there's any movement at the anal sphincter. It is going to be followed by an anal sphincter contraction test by inserting a digit to the depth of 1 to 2 knuckles into the anal sphincter and feeling for contractile strength. The strength of the contractions are there compared to baseline to see if there's any improvement. So if you are going to work in spinal cord injury, the normal question I get is, do I ever have to do this? And I will say, yes, you will. So most people, yeah, it was like, oh. Now, most people get kind of embarrassed by this. I'm going to stick my finger up somebody's behind. Isn't that embarrassing for them? You have to remember something. Most of these patients you're going to be doing this with aren't going to feel it. Right? They're going to be asensate. They're not even going to know you're doing it. Right? Because they've got a spinal cord injury. And honestly, if they can feel it, they actually get happy. Dylan's exactly right. If all of a sudden they're like, woohoo, right? Or what was the dog from Dr. Doodle? Hello, right? If that happens, they're actually kind of happy about that because now all of a sudden they've got something they didn't have before, right? So the only thing that usually freaks people out is, wait, 1 to 2 knuckles? Yes, 1 to 2 knuckles. And what you're testing for is, does it squeeze around your finger, right? And yes, you're going to wear gloves, and yes, you're going to use the appropriate lube and stuff like that. Yes. Get all that giggling out now, because the next one's worse. The next one is called the Bulbo Cavernosus reflex, or the BCR, or the Bulbospongiosis reflex, BSR, or the Osinski reflex. Most of the time we refer to it as the BCR, the Bulbo Cavernosus reflex. This is used to monitor for anal sphincter contraction in response to squeezing the glans penis or the clitoris. So this is, you squeeze either the clitoris or the glans penis and see if there is a reaction in the anal sphincter. Again, this seems really embarrassing. But again, these are spinal cord injury patients, and if they get a reaction out of that, they're actually happy. And there's no laughter allowed there. Both can be tested electronically using eStim, or the other way that you can do this that's kind of mean is you can test it by tugging inferiorly on an indwelling Foley catheter. I have never done that. I've seen a doctor that did that, and I think that is the meanest possible thing you can do to a patient. So if they've got a catheter in their urethra, if you pull down on it, because of the balloon in the bladder itself, it will trigger the BCR. It'll trigger their butt to kind of clench, right? But I think that is just, yeah, that made your stomach drop, right? Yeah, it was like, oh God. And why did they do that? Because the doctor doesn't want to do the other tests, right? I would much rather myself be uncomfortable doing an anal sphincter reflex and a BCR versus pulling on that catheter. If any of you have ever had a catheter and had it pulled, you will understand why I'm saying this. That is quite possibly the most uncomfortable feeling you will ever feel. And like Eric said, it does make your stomach drop because that's kind of what it feels like. Your stomach kind of feels like it's falling out. So we'll do this initial evaluation of this, or a reevaluation of this, right? When I worked at a clinic that did spinal cord injuries, a lot of times I did the ASIA assessments because the PT didn't want to do this. And I wasn't going in and finding out what the problem was. I just was reporting what I found, right? The PT's like, go do an ASIA assessment on 304 for me. Okay, sure. And then they would take my data and interpret it for the goals. So it's completely possible that you may do this if you're working in a clinic that's spinal cord injury patients. If they don't, it may be performed by doctors. I've been in a spinal cord injury clinic before where the docs always did the ASIA assessments. Okay, great. That means we don't have to do it. But you have to know what they are. So you will have to know the difference between the anal sphincter reflex and the BCR, the bulbo cavernosus reflex, right? One is literally getting the skin, the anal sphincter to pucker from stimulating the area around it. The other is getting it to pucker by doing other motions, typically by squeezing the glans penis to the clitoris. And again, like Dylan mentioned, if you get a reflex out of a patient that didn't have it before, they're usually happy. They don't care that you're doing it, right? They would rather get a reflex out of it than not. The one thing I will warn you, and this is kind of the gross part about this, if you do the ASR, the anal sphincter reflex, on a patient that has no bowel and bladder control, same thing actually with the bulbo cavernosus now that I think about it, a lot of times by stimulating that, you will trigger a fecal release. And it's not something you did. It's not something for the patient to get embarrassed about. It's just that the body detects that and releases, if it can, any matter that it has to be released from the bowels. It happens. And again, it should be something that they're happy for, right? Because that helped clean out anything that was in there. But just be aware of that. It happens. So we're going to have a patient that's going to come in. Let's just we'll have a patient, they'll come in, and I need a different color than purple. Let's go dark red. It'll say that they are a traumatic, I can spell, SCI with an injury level T1, a neuro level of C4, and say that they're a complete. So what that tells you is they had some sort of a trauma, whether it's motorcycle, violence, whatever it may be. The trauma occurred at T1. The last area with full function is C4. And they are complete, meaning they have no control over bowel and bladder. Does that make sense? Does that kind of give you a picture of what your diagnosis is going to show like on your spinal cord injury patients? All right. So let's take a break before we talk about incomplete, because incomplete's a little bit more of a weird topic to talk about. So let's take a 10-minute break here. Let me get where's my phone at? So let's take a 10-minute break. We'll come back here at about 5 after. So I'm recording. All right, so we're recording again. So we talked about the complete injury last. The complete injury is any injury where the patient loses full function of S4, S5. So that means if we have a complete, we also have to have an incomplete injury. And an incomplete injury, right, gives us an idea of what we're looking at. An incomplete injury says there is either sensory and or motor and or sensory function below the neurological level, including some or all function at S4, S5. So in order for it to be an incomplete injury, let's say I'm a T4 patient, right? In order for me to be classified as incomplete, I would have to have some function below T4, including some bowel and bladder. It may not be fully functional bowel and bladder, but some functional bowel and bladder. So that comes in another a type of incomplete injury is patient has zones of partial preservation. These are patients who have complete spinal cord injuries, in quotes, where they have no bowel and bladder control, but they have some motor and sensory function below the neurological level. So if I'm again a T4, maybe T6 is fully functional or partially functional, but I have no bowel and bladder. That means at T6, I would have a zone of partial preservation. And then there's this term called sacral sparing. This is an incomplete lesion in which the most centrally located sacral tracts are spared. So everything at the sacrum, so everything S1 through S5 are spared. And again, it's all going to depend upon how the patient gets injured. So we have to understand that what the difference between a complete and an incomplete is, first of all, right? So complete, no S4, S5, incomplete, some S4, S5. A zone of partial preservation, no S4, S5, but functional levels below the injury. Not total, it can be just minor, it could just be sensory. It could be that, I'm a T4 and I have feeling in my quads. That would be a zone of partial preservation. And in sacral sparing, if I'm a T4, but I have full S1 through S5 function, that would mean I'm sacrally spared. Now we get into the syndromes. Just like we talked about the syndromes with CVAs, we have syndromes with spinal cord injuries. One of the big ones, and unfortunately it's one of the ones I see more here than I've seen back when I was in Pennsylvania, are brown Sicards. Right? This is not a brown Picard. We're not putting Captain Picard in a brown Star Trek uniform. This is a brown Sicard syndrome. This is a hemisection injury. It occurs when the spinal cord, usually partial, and is typically caused by a penetration wound. Gunshot, knife injury. I've seen a pipe through the spine. So the spine is going to go through, usually the injury is going to come laterally through the spine, and one side is going to be affected. If you have a Brown-Séquard syndrome, typically those lateral tracts are what's going to be affected. So you'll have ipsilaterally, so same side. So if I'm stabbed on my right side, I'm going to have deficits of the corticospinal tract. And is corticospinal motor or sensory? Corticospinal. Corticospinal, motor, there you go, right? Going from the brain to the spine. And then dorsal column loss below the injury site. So if I'm stabbed, let's say at T5, I'm going to lose motor function on the same side below that. I'm going to lose proprioception and vibration sense. On the other side, on my left side, I'll typically lose pain and temperature sensation because I'll lose the lateral spinothalamic tracts, which are desiccating tracts. They cross over. If I am a Brown-Séquard, this is probably the best case scenario for me because I have a really good prognosis for motor return. If I'm a partial injury, I have a really good chance of getting most of my function back, or at least some of it, if nothing else. So if there's any kind of silver lining to getting stabbed or shot, and getting shot and stabbed in the spine, is you have the best chance of actually getting function back. Now we have an anterior cord syndrome. So the front of the spinal cord, right, is where flexion's occurring. It's related to flexion injuries of the cervical region with damage to the anterior cord and its vascular supply from the anterior spinal artery. Direct compression of the anterior portion of the spinal cord, i.e. whiplash, cracking forward and cracking back. With an anterior cord spinal cord injury, the lower extremities are affected more than the upper extremities. So typically bottom half on an anterior cord syndrome. You're going to lose the lateral corticospinal and the lateral spinothalamic tracts. So you're typically going to lose pain sensation, temperature sensation, motor sensation below the injury site bilaterally, because again, this is an injury in the front side of the cord, not specifically lateral. So both of those sides, the lateral corticospinal and lateral spinothalamic, are going to be damaged. Again, if there's any positive sign out of this, the dorsal columns are typically preserved, right? The spinal cord is designed to stretch a little bit, and they're on the back side. So as I lean way forward, they're going to stretch out, and they're not going to tear typically. The ACAs or the ACS have the worst prognosis for incomplete and even complete injuries, right? Even an incomplete injury may mimic complete cord syndrome because of the front side of the cord being damaged, because that's so much that goes on up there in that front aspect of the cord, right? There's only about a 10% chance of motor recovery. So if you have a patient that says they're a, say they're a T12, T12 anterior cord syndrome, and they say to you, I'm going to walk again. We're going to walk by next month. In your mind, you should really be thinking what? Nope, not going to happen. Right? Now, we may still give them encouragement. We may try to overcome that a little bit and not, let's not get our goals too lofty here. Let's start by taking one foot in front of the other, and taking one foot in front of that's not a good way to say it. Let's start by taking one step at a time and see if we can get you out of bed first, right? You don't want to totally destroy them the first time you see them. And honestly, you should try to be a little bit more encouraging. But if you have an anterior cord syndrome, not a likely chance of recovery. Excuse me. Central cord syndrome, right? It occurs from a hyperextension injury to the cervical region or congenital degenerative narrowing of the spinal cord. Your upper extremity is going to be more affected than the lower extremity. So for ACS, lower more than upper, CCS, upper more than lower. And again, typically your hands are going to be more pronounced than the arms. Well, why is that? Well, the upper extremity tracts are more centrally located in the corticospinal tract. So the tracts that send stuff down to the hands are more towards the middle part of the spine. So this is going to occur from injuries that go back like this, right? That means the center part of the spine is being squished and compressed. Sacral sparing is likely. Usually they're going to have bowel and bladder. This is where it gets weird with these patients. So for a central cord syndrome patient, they're going to have lower motor neuron signs in the arms, upper motor neuron signs in the legs. So the upper extremities are going to look like they have no motor function. And the lower motor extremities are going to look like their central nervous system's damaged. It can happen with narrowing of the canal, stenosis meaning narrowing, right? With spinal cord edema, and it causes compression on the cord. Usually selective destruction of the lateral corticospinal tract, white matter. They often have hyperpathia, exaggerated pain response to nociceptive stimuli, meaning that if you cause them pain, right? If you take out and you do that little, you take off your that little pin at the top of your reflex hammer, and you put it down in them to cause a little bit of a pain sensation, they'll have an exaggerated response to that. They'll also have burning present in the upper extremities, right? It'll feel like they've got that nasty burn going down their upper extremities. Because your motor tracts are more centrally located, they're more affected than your sensory tracts, right? This is the most common incomplete spinal cord injury, right? So this is the most common incomplete, so a hyperextension injury. Again, mainly because they have sacral sparing. Usually S4, S1, S2, S3, S4, S5 are functional. Posterior cord syndrome are caused by penetrating trauma to the posterior spine or severe hyperextension with vertebral arch fractures. So penetrating trauma, you can't avoid, right? Why would a severe hyperextension injury be really rare in a human being? What prevents us from super hyperextending? Do you remember what that protective device is on the front side of the spinal cord that prevents us from really hyperextending? It's that long, flat band of fibrous tissues on the front side of the spinal cord, on the anterior side. If it's on the anterior side, it's probably called something anterior. And it runs the whole length of the spinal cord. So what's the term for running a whole length of something? Anyone remember from back in midterm? It's the anterior longitudinal, there you go, anterior longitudinal ligament, right? The ALL. That is that long, thick, broad band of a ligament that covers the whole front of the spinal cord. It has two jobs. It prevents your spine, your bones, your spinal bones from coming forward into your cavity where you have organs, right? The other thing it prevents is super hyperextension injuries, because it literally, like if you ever do a dissection of cadaver, that ALL, it looks like a really super thick muscle. It is beefy. And when you think about it, it's gotta be, right? It's designed to keep those spinal cord things from coming forward. Well, it's also then designed to prevent hyperextension. Well, what could cause severe hyperextension? The one case I've seen of posterior cord syndrome was a guy that was a construction worker, and he was working up on a couple, like, I think it was five or six level, not levels on the term, floors high, and he lost his footing. And when he lost his footing, he fell over the edge. Now, he had a tether that kept him from going the whole way down and smashing to the ground. But what he ended up doing is coming down on a girder and basically bending backwards. So his body, you know, so here's the girder. His body did one of these, right, around the girder. That obviously, yeah, right, whoa is the right term. That obviously is an extreme hyperextension injury, right? And when that happens, because the most posterior aspect, this is posterior cord syndrome, right? The most posterior aspect are your dorsal columns, means you usually lose all proprioception. Proprioception is just gone. You'll usually have preserved motor, pain, and light touch, because those are more centrally located, and temperature, because your spinal thalamics are intact. This is an extremely rare, but in cases like this, right, I was joking, I'm like, I've never seen a posterior cord injury. I guess I shouldn't have jinxed myself, because then 6 months later, we had this guy come in. And it was just a weird case, because it was a partial, obviously an incomplete spinal cord injury. He had most of, the only motor function he lost is he lost pinky function, which was really weird, right? He had functional upper extremity and lower extremity motion, but like his pinky did the whole English thing when he was picking up drinks, right? Or he's doing the mahala, right? His pinky just stayed stuck out there no matter what he did. And then eventually the pinky kind of contracted up and almost into like a trigger finger posture. So that's posterior cord syndrome. right? So if anterior is kind of the most common, central cord is the most common incomplete, posterior cord is the least common spinal cord injury. Now we're going to Yes, exactly. I don't remember who that was either, Dylan. That's a great comment. He said, is that the same injury that there's a baseball player who dove for a ball on the wall and his feet touched the wall while his head was at the bottom of the wall and he kind of bent backwards. Yeah, he had a posterior cord syndrome. Yep. I don't remember who it was. I'll have to look it up maybe on break, but you're thinking exactly right. He kind of did that backwards bend motion. And I'll see if maybe I can find the video too. I'll have to look. So now we move on to a little bit outside of it. So now we're going to talk about root escape injuries, right? Or if you call it from Pennsylvania, root escape injuries. Because we don't have roots, we have roots. So a root escape injury is a PNS injury with potential for return of function. So what I had when I had my spinal cord injury was a root escape injury. This is preservation of the peripheral nerve root at the injury level, but depending on how high up the axon the damage occurs, the less chance for neural regeneration, because mine occurred after my horn cells, right? And out here at the lateral aspect of my spine. The further up the damage, mine was right at the spine. So that's just the way it is. The less chance for regeneration. And this is the interesting part. If you study spinal cord injuries, they'll say that PNS nerves can grow back less than 1 inch per month to less than 1 millimeter per year. So really what it says is we know nothing about the regeneration effect of peripheral nerves, because some people are saying, well, it'll grow back at less than 1 inch per month. And then other people are saying, well, we don't get less than 1 millimeter per year. So when we get that regrowth of nerves, it just is kind of a spontaneous regrowth. We don't really know why it occurs or how it occurs at this point. That's something they are researching, and is it possible to do, stem cell inserts to help that regeneration effect? Cauda equina syndrome. This would be another one I would star because this is important. This is a peripheral nervous system or lower motor neuron injury, and it is usually incomplete. This is a dire medical emergency and usually occurs in the orthopedic setting. So some key symptoms, then I'll talk about a patient I had with this. Key symptoms. Patient will present with bilateral leg pain, usually describing it as burning pins and needles. Oftentimes we'll mistake it for just normal peripheral neuropathy due to nerve impingement. Patient will have bowel and bladder dysfunction, often sexual dysfunction, and saddle anesthesia. What they'll talk about is the inside of my legs are numb, right? Saddle anesthesia, where you would normally sit on a saddle. And they'll have bilateral or unilateral sensory motor changes. So it may not be even on both sides. So this is a patient. I have a patient. We're going to call him Bob. This is when I worked at a clinic on the west side of town. Bob came in. He was a paramedic. And Bob was eval'd by Kate, who was our PT. And Kate was a really sweet girl and really nice. And, all the patients loved her a ton. But Bob came in presenting like he had low back injury, because he kept talking about how he has kind of burning and tingling down his legs and his back hurt. Well, when that kind of comes in, and because he was paramedic, he had really good insurance, literally his pain started the day before. He was in for an eval the next day because we had a slot. And he was like, I'll take whatever slot you have. And it happened to be like a 7 o'clock slot. He was in there. So Bob comes in to see her, gets the eval done. Then he's like, okay, I want to get this going. So he comes to therapy the very next day and sees me. And so Bob and I are talking, and we're doing some, some pelvic rotations and stuff like that in the treatment room. And he says to me, he goes, hey, McKeever, he goes, I just got a question. I'm like, okay. He goes, is it normal for low back pain to cause, you not to be able to, go pee? Red flag. And I'm like, well, no, not normally. I said, unless there's problems with it already, unless you already have bladder problems. And I said, what about erections? Are you having problem with that as well? He goes, now that you mention it, yeah. because I didn't want to say anything to Kate because he didn't want to, again, it's a guy. He doesn't want to say anything to the female physical therapist. This happens very frequently. And it's very common the other way around as well. If you're a male physical therapist, females don't often want to tell male physical therapists all their symptoms. They'll react better with a female PTA. So now I've got, you know, I've got bladder issues. I've got erection issues. So I got sexual dysfunction. And I'm going here to see if I can get the hat trick. I'm like, what about the inside of your legs? And he's like, man, they've just been the numbest for the past 2 days. Do not pass go. Do not collect $200. I said, hey, I said, just hang out for a second. I want to check with Kate real quick. So run out, and we had to call the ambulance on him. Because if they don't get decompression within the first 2 days of this, they will lose all of that stuff and the symptoms will become permanent. This is the cauda equina literally being pinched off. Oftentimes it gets pinched in the actual spinal cord itself. And as those symptoms increase in intensity, the urgency of treatment increases. And if it doesn't get decompression, it can lead to permanent paralysis. So that they had to go in, and sure enough, at about L5, he had a vertebral subluxation where he was picking a patient up and putting them onto a gurney, and the vertebrae slipped, and now his cauda equina is pinched between L4 and L5. And so they had to go in and relocate L4, L5. And then once they did that, his symptoms pretty much resolved. The only thing he had, we saw him a couple months later because he came back in for therapy. The only thing he had kind of residual was a little bit of saddle anesthesia. And his comment was, I'll deal with loss of sensation on the inside of my legs if I've got full other function back. And he did. With both root escape and cauda equina injuries, whatever the patient has status post 1 year out is typically what's going to return for them. So if they don't get all their full function back by 1 year, like for me, right, with my root escape injury, I've lost sensation in this arm. At a year out, I knew, this is why I knew as soon as I got a spinal cord injury, I started doing therapy as soon as I could, because I knew at a year, if I didn't have motor function back, which I do have motor function back, if I didn't have motor function back, I wasn't going to get it. So that motivated me, right? Same thing with cauda equina. If they have the same symptoms at a year out, they're going to have those symptoms for the rest of their life. It's very rare that if you see a patient with either of these syndromes and they're, 2 years out, that stuff's going to go away. Oftentimes we have to teach them to deal with it for the rest of their life. It's kind of sad, but that's just the way the body works. Spinal shock. This is a temporary brief period of loss of spinal cord function, motor function, flaccidity, reflex activity, below or up to the injury level. It may last several days to weeks, but it usually does resolve in about 2 days. It's due to swelling and natural injury response, and the neurons become hyperpolarized and unresponsive. So what this is saying is, let's say I am a T4 injury. So we'll call this a T4. Well, if I have a T4 injury, the body's going to come in here and swell all around this area, right? Because the body's creating its natural cast. Well, when that happens, that swelling occurs, right? All these levels below and maybe even a few levels above are getting compressed. So maybe when they first report to the ER after a spinal cord injury, they may have less function than they have 2 days later. Well, that's because the swelling was up at that point. And what happens is, if you remember, do you remember that action potential curve with a neuron, right? Where the neuron goes along, it's firing, right? And then all of a sudden, bing, it fires off an action potential. And then after the action potential, it comes down here, becomes hyperpolarized where nothing else can occur. Well, when you have this spinal cord shock, all your nerves get stuck down here in this hyperpolarization phase. And the body does that to help healing, right? So spinal shock is normal in the first couple of days after. It's why we don't always say to the patient, well, hey, this is where you're at right now, because we may not know in the first couple of days of a spinal cord injury. After we get past the 48-hour point, then we can start being pretty confident about what kind of an issue they have. Neurogenic shock. This is characterized by hypotension and relative bradycardia in acute SCIs. So this happens when you have problems with the autonomic pathways of the spinal cord, those visceral nerves, where they're now not providing enough information. You have lack of sympathetic tone and decreased systemic vascular resistance. So you're going to end up with hypotension. Blood pressure is going to drop drastically. And when blood pressure drops, the heart rate's also going to drop. This leads to pooling of the blood in the extremities. So if you have a patient that has a spinal cord injury, we're going to be looking at their skin regularly because we want to make sure that they're not going into this, what's called neurogenic shock. Because as that blood pools and collects maybe in the feet, what's it going to start doing? What happens to blood as it sits around and just lays there? Yeah, it starts clotting. Right? So now I'm in neurogenic shock because I've got a spinal cord injury. You know, my overall heart rate's low, my blood pressure's low, my blood starts pooling in my feet, I start getting a clot. Now I end up losing a foot because I got a bad blood clot in the foot. Or worse, that blood clot suddenly breaks loose, travels to the lungs, and I end up with a pulmonary embolus or a stroke in the brain. Right? So a lot of these patients that are in neurogenic shock, they're going to give medications to raise their blood pressure. It's funny, I'm consuming one of the medications we may give them. What do you think it is? Caffeine. Caffeine raises your blood pressure, right? It also raises your heart rate and everything else, right? That's why if you look at most supplements that you'd get at the gym, most supplements have caffeine because they'll say increases your tolerance to workout. Well, what it's really doing is increasing your blood pressure and increasing your heart rate so you can perform at a higher level, right? Same idea why we drink it in the morning is because it kind of gets us going, right? Yeah, pre-workout's important, right? And then motor and sensory impairments, anything that's odd, just is going to depend upon the level and the extent of injury, right? If I have a Brown Séquard where the stab is only the tip of the knife, they may not be fully Brown Séquard-y, right? But if I have somebody that knife goes all the way through and hits the dorsal columns, they may even have further damage that's not normal for a Brown Séquard patient. So just like we talked about with patients that have neurological conditions, just like we talked about TBIs, just like we talked about strokes, these patients can vary. Out of all the neuro patients, though, spinal cord injuries follow closest to their patterns. It's pretty rare that I see a central cord syndrome that looks like an anterior cord syndrome. I don't think I've ever had that. Again, I haven't had many central cord or posterior cord syndromes. Most of the time it's been anterior cord syndromes. But, you know, with the stroke, it's been common where I've had an anterior cerebral artery syndrome that looks like a posterior cerebral artery syndrome because the brain's a little different than the spinal cord. So be aware that when you're working with a spinal cord injury patient, most of them are going to follow these similar patterns. You may still have some weird things that happen, you know, where the patient loses their pinky and that's the only muscle they lose. But for the most part, the stuff is going to follow a kind of standard style of attack. All right, another starred page, please. If you honestly, I'm going to say with this one here, not only I want stars here, I want stars here, I want stars here. I'm drawing really bad stars. So I have oh, there we go. Here we go. Put stars all over this page. Stars everywhere. Lots of stars. Change the stars' colors. Different colored stars. Why is it only yellow? Give me a different color. It's only giving me yellow stars. Whatever. It's like Lucky Charms. Right? Why do you think I'm saying star this page like crazy? What do you think the reason I'm telling you to star this page like crazy is? Adrian's exactly right. This is the thing that the boards ask questions on for spinal cord injury patients because this is a safety issue. This is autonomic dysreflexia, also known as hyperreflexia. This is a pathological reflex that occurs in injury levels above T6, but can also be seen as low as T10. Now, I want to warn you, we're talking about spinal cord injury patients with this. This is not 100% exclusive to spinal cord injury patients. But when you have board questions on it, it is going to be in reference to spinal cord injury patients. It'll say your patient is a neurological level T4 spinal cord injury patient and presents with the following symptoms, right? They're not going to ask you, but I have seen autonomic dysreflexia occur in people that don't have spinal cord injuries. And we're going to talk about that in a second. Autonomic dysreflexia is typically caused by catheter retention, particularly urinary catheters, with symptoms critical due to the lack of inhibition from your higher sensors. So your brain is not, and your spinal cord aren't inhibiting the bladder as much. It is an afferent stimuli problem with signals being sent back to the brain where they're getting interrupted. The symptoms include patient's going to have blood pressure, hypertension. It is going to be remarkable. And when I say remarkable, I saw one patient that I was working with that got autonomic dysreflexia, that his BP was normally at baseline 120. When he started having symptoms, his blood pressure went to 300. Right? That is, what that is that is a stroke waiting to happen. Right? At that high of a level, that's blood vessels bursting pretty much everywhere. Right? It's not uncommon for them to be greater than 220. Diastolic, not so important, but that means that pulse width is going to be greater, right? That difference between diastolic and systolic. Because the hypertension goes up, the body is going to depress the heart rate because it's going, okay, if I have a high heart rate and a high blood pressure, explosions. So it's going to suppress the heart rate. So you're going to end up with bradycardia, oftentimes severe. This guy, the specific one that I'm talking about, I remember his blood pressure was at 300. His heart rate was in the 40s. Right? So now it's telling you your body's all over the place. You're going to get a severe pounding headache. Why do you think you're going to get a severe pounding headache? What's the pounding? This is like subwoofer cat. Your head is literally going doof, 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 doof. Yeah, it's the blood pressure, right? It's literally your blood vessels in your brain squeezing, right? They'll have diaphoresis. They'll be sweating like crazy. They'll start getting spasticness. They'll become very restless and anxiety ridden. Oftentimes they'll tell you, I don't feel right. And that's when I joke and say, well, I don't feel left either, but what's going on? Huh? Get my joke? They say I don't feel right. I don't know. Okay. Typically, you'll have vasoconstriction below the lesion level, vasodilation above the lesion level. Not that important for you guys. It's just something that happens. You know, it's not like you're going to check for vasoconstriction and vasodilation, but it just does happen. The pupils, man, this dude's pupils became pinpricks. You could barely see them. You get nasal congestion, right? Oftentimes you get blepharitis. You'll get rhinosinusitis. Pilo Erection, which is nothing more than what? What is a Pilo Erection? Yes, goosebumps. Like some people are going, I'm not answering that one. That's dirty. No, Pilo Erection is goosebumps, right? And oftentimes what I've seen, and I saw with this patient particularly, he had goosebumps above in his upper extremities, but his lower extremities were not goosebumpy. And then suddenly, if you keep going, the patient's going to start feeling doom and gloom. So what's the patient going to say? What does the sensation of doom and gloom turn into when they're saying stuff? Yeah, what's the point of living? Oh my God, I'm going to die. Something's wrong with me. You know, I got to get out of here. Right? They start getting apprehensive, and then eventually they'll get blurred vision. Right? Any elevation of blood pressure when you have a spinal cord injury patient that is greater than 40 millimeters of mercury over their baseline is cause to suspect autonomic dysreflexia. So in this case, right, so we'll call this patient, I don't know, we're going to call him Martin. And Martin and I were working in his room, and he's sitting there, and all of a sudden he's like, man, is it normal for me to get a headache? And he was a T12 spinal cord injury. No, he wasn't. Never mind. It's T4. And I'm like, well, I mean, you know, it's possible, right? It's when somebody just tells you they have a headache and they're in the hospital, good Lord, have you ever been in the hospital? Everything's beeping, everything's ringing, everything's dinging. You have John down the hallway going, ah, I'm dying. I broke my femur. I'm at a 10 out of 10. Sorry. Relating it back to the comedy skit, get it? But I'm like, okay, well, let me know. What else are you feeling? And he's like, well, man, I'm feeling kind of shivery. And about that point, like sweat literally started beading all over his forehead. And I'm going, oh boy. You know, my boy, and this is the first patient I ever had with autonomic dysreflexia, and it was on my second clinical rotation. And this, or no, sorry, my third clinical rotation, because it was an outpatient. Or no, it was inpatient. It was inpatient. So it was my second. Anyway, neither here nor there. And he's like, I'm starting to feel something's going on, man. I'm not feeling good. Oh God, what's going on? This will become life-threatening. They can stroke from this. So you need to be aware of it. I had to recognize within an instant and figure out something was wrong. Well, what happened with Martin is the nurse had come in to drain his catheter. And when they drain the catheter so they can measure it, there's a little green kind of clampy thing on the catheter that they can clamp off so that when they drain the catheter, they only get what's left in the bag, right? So they can measure that, and then they'll open that back up and start filling the bag again, right? Well, the nurse came in, drained the catheter, but forgot to reopen that valve. So now that whole urinary catheter line down to that valve is filled up. That means urine's starting to back up into his bladder, and it had been that way for 4 hours. They hadn't noticed it. So now urine's not only backing up in his bladder, but it's backing all the way back up to his kidneys. So luckily, I listened to my neuro-specialized PTA that was in my program, and the first thing I did was got him vertical and checked the catheter, right? So I got him sitting upright because that was the best I could do with him. And I checked his catheter, and sure enough, I saw that was pinched off. As soon as I opened it up, literally 500 milliliters of urine came out instantly, just gushed into the bag. It was like somebody opened a hose. And within a few seconds, everything started going back to normal. I was watching his blood pressure on the screen. It started going down. His heart rate started coming back up. And he started feeling instant relief, right? The interesting thing about this, it can become chronic and recurrent, meaning the more that he has these problems, the more likely this can occur. So he's had it once. The chance that the next time he has it, it'll probably be worse. It can occur with ulceration and lesions in the bladder as well. It may also occur from recurrent hemorrhoids, right? What are hemorrhoids other than little children? No? No one laughed at that one? I thought it was funny. Yeah, your insides of your butt trying to get out, typically blood vessels, right? It's portions of your actual lower colon kind of peeking out through your butthole, right? And oftentimes, I don't know if any of you have ever experienced a hemorrhoid, but they are definitely not fun, right? They make going poop very hard. What's a common sign of having a hemorrhoid? Does anyone know? Other than hurting when you're pooping. Yeah, blood when you're pooping, right? And sometimes it can be copious amounts of blood when you're pooping, meaning a lot of it, right? So if you have hemorrhoids, well, that's going to potentially block off you from pooping. Or the worst, if you do have some bowel and bladder function, you may not want to poop because You have hemorrhoids. So you start holding in your poop and you start becoming like that little kid, right? Did you ever see that little kid that you're working with? He's like, and you're like, Johnny, do you have to poop? No, I don't have to poop. And you're like, are you sure you don't have to poop? Nope, I'm fine. And he's over in the corner, kind of like popping a squat. Johnny, do you have to poop? No, I'm okay. Well, same thing can happen here with an adult where they'll try to hold in the poop because every time they poop, it hurts. You didn't think you'd be talking that much about the butthole and poop in one day, did you? If the patient gets impacted, you remember what impacted means again? Yeah, more than clogged, it becomes concrete, right? What do you think, what could cause somebody to become impacted? Well, other than lack of bowel and bladder, because that could cause it. What else could cause them to become impacted? Inflammation and swelling, good. Pain meds. I don't know if any of you have ever taken long-term opiates or taken opiates for a long period of time. I hope none of you ever have to do that. Like, I really, if you guys can avoid taking opiates, although they sound like a ton of fun, they aren't, right? You know, when I broke my neck, I was on a long-term dosage of opiates. And let me tell you, that was the most miserable time of my life because my pain felt great. Actually, nothing felt like anything. But holy crap, literally, it turns your insides into lead. And so patients that are on long, and you got to think about it. If I have a spinal cord injury, do you think they're going to be on opiates? Yeah, right. And oftentimes they're going to be on the strong stuff. They're going to be on Demerol. They're going to be on, you know, fentanyl patches. They're going to be on the good stuff, right? And so that's going to block them up. Oxys, right? Yeah, it's going to block them up. So all of that can cause autonomic dysreflexia to occur. It may be treated if it's a long-term effect where it's just kind of happening because of lack of bowel and bladder control. You can treat it with alpha blockers or calcium channel blockers. Where did you hear those medications before? Alpha blockers or CCBs, calcium channel blockers. Patients that have what? Have you heard of those meds before? Yeah, people with high blood pressure. Exactly. Good. So people with heart, you know, people with blood pressure issues, people with congestive heart failure, often are on alpha blockers or calcium channel blockers because it affects the overall function of the heart, right? So complications, if you keep having this effect, they can end up with acute hypertension, meaning that blood pressure stays at that high level, right? Cardiac myopathy, specifically dilated cardiac myopathy. Have you guys heard of that before? I talked briefly about it with COVID. Dilated cardiac myopathy is where the heart kind of goes and swells up, right? Seizures. Well, that makes sense. If my blood is pounding into my brain's eventually going to go error, error, throw a blue screen, and that's the seizure, basically. Windows users will get that. Or if you're a Mac user, your brain will throw the pinwheel of death. Pulmonary edema. Well, that kind of makes sense, right? Why do you think the lungs are going to start swelling if your heart's not pumping right? Well, because the blood literally isn't getting out of the lungs. So the lungs are going to start getting swelling. Can lead to a heart attack. Ultimately, the main thing here is cerebral hemorrhage, right? A bursting of the blood vessel in the brain, which is also known as a what? A CVA, right? A stroke. Patient can stroke from this. Long term, it will lead to nephritis, inflammation in the liver, or ARF. If you see ARF on a chart, that means the patient is in kidney failure. And this is sad to say, but let's say anytime you see a patient with a diagnosis of an F, right? So acute renal failure, congestive heart failure, acute respiratory failure, are they going to get better ever? No. Right? And I'm sorry if this hits anyone at home, because maybe you have a mom, dad, uncle, grandpa that has congestive heart failure. At the point that you start getting into that failure, you are waiting to die. Because when you get to the failure point, those organs have started to die. And there's just no going back from that. Now, you can get a transplant, stuff like that. That's a different story. But your organ has failed at that point, right? So, autonomic dysreflexia, your response is always change the vertical position, check the catheter. Change the vertical position, check the catheter. And when I say change the vertical position, you're either going to sit them up, stand them up, lift them up. Any of that is valid, because what you're trying to do is stretch out the ureters, give more room for the kind of urine to back up, or stretch out the lower bowel so that it has room to back up. Okay? So what is a question going to look like on the board? It'll say, Johnny, your patient, is a patient who suffered a complete C5 spinal cord injury. Now, when it says complete C5 spinal cord injury, what they're telling you is he has no bowel and bladder function, and his neurological level is C5. If it just lists the C5, that is the neurological level. Does that make sense? They will, if it says insult or injury level, that's different. But if it just says complete C5, that's his neurological level. And you are working with Johnny in the gym. Johnny starts complaining of feeling cold in the gym, complains of nasal congestion, and his blood pressure upon taking it is 250/80. What is your course of action with Johnny? And the first answer is going to be lie the patient down, which in any other condition would be our normal response, right? If the patient's having these weird acute symptoms, our normal response is going to be lie the patient down. Why do we not want to lie a patient down? What happens when we lay down? Yes. Twink get worse. I like it. It wink gets worse. Thank you, Scan. That gave me a little bit of the humor at least. Yes, when you lie down, your blood pressure goes up for a brief period of time. So now he's at 240/80. You lie him down, now he's at 280/80, and he strokes on you. Right? So it'll say that. It will say, call a code. Get a nurse, stand them up, check the catheter. What is the option that's right there? Stand up and check the catheter, right? Yes, because while call a code is technically would be a valid answer, right? Because he is going into some problems with his autonomic system. It's not the best answer, because you can stand him up, check the catheter, fix the catheter, and this can resolve. And then you don't have to call a code. They don't have to bring the crash cart. All the doctors don't come rushing to the gym. And you're the hero of the day. And ultimately, we all want to be the hero of the day, right? We want to have them playing Metallica's Hero of the Day in the background for us. So what type of catheters can cause this? Let's talk about catheters. So we know urinary catheters, right? What about a condom catheter? Could a condom catheter cause this? So condom catheter slips over, obviously, the penis, just like a condom would. Do you think that would cause this? I know everyone's so excited talking about catheters. Well, not usually, because let's think about it. If you have something slipped over the penis and pressure builds up, what's probably going to happen to the catheter? Yeah, it's going to fall off. It's going to explode. Literally, is what's going to happen. You're going to pee everywhere in the gym, right? That's pretty much what's going to happen with the condom. So it's going to be those indwelling catheters, whether it's a Foley or whether it's a Swan's-Ganz where they're actually putting it into the bladder through surgery. One of those two types of catheters, right? You can have a fecal catheter. Did any of you encounter anybody with fecal catheters in your clinics? Because they do exist. And the first time you encounter it, it can be a crappy situation. Good, I made Michelle laugh at least. Because a fecal catheter is exactly like it sounds. It's going to be put up the bottom, and it's going to go to the base of that colon, and all the poop's going to come down through that. The only reason I say it can become a poopy situation, usually they're on a fecal catheter because they are severely incontinent with diarrhea. And so you accidentally pull that fecal catheter out, which happens, unfortunately. I've done it twice. I know, I made mistakes. But you pull that catheter out, now there's nothing collecting that diarrhea, and it literally becomes a crappy situation everywhere. It's like, I did a patient with MRSA. Oh, that's fantastic. At least think of it this way. You know, at least it wasn't something that caused the poop to become stinky. Think of it that way, at least. Right? Here's the thing, though, that we don't think about a lot. IVs are catheters. Right? Especially the ones that go in the neck, which are usually, again, Swan's-Ganz type catheters, because they have the same type balloon. They are catheters as well. So I have seen, and I actually had I didn't have the student, it was one of the students that was in the hospital working with another PT, where the problem wasn't the urinary catheter, the problem wasn't the fecal catheter. They had an indwelling catheter in their neck that was running up to a VP shunt, which was in their brain. And that VP shunt was draining excess CS fluid out of the ventricles. And it was supposed to go to the stomach, but they hadn't finished putting that in yet because they were testing it with the patient. The nurse came in to drain the shunt and pinched it off just like a normal catheter, and then forgot to open it up. And the patient started presenting with autonomic dysreflexia because it was catheter up here. So don't rule out all their other catheters. If you're going to stand them up, you're going to check all of their catheters. Right? So be aware of that. Does that make sense? Did I beat this into you enough? So autonomic dysreflexia, stand them up, check the catheter. Autonomic dysreflexia, stand them up, check the catheter. The only reason I say change their vertical position is because if you have somebody that's a C4, you're not likely to stand them up. Right? If they're a C4, they've got almost no motion whatsoever. Go ahead and try to stand them up. Good luck with that. At least get them sitting up. Now, let's say it's really severe. Could I lift that patient up and hold them upright and have somebody else check the catheter? Sure. Absolutely. Right? That's where you get your good old big old bear hug on, get them under the arms and kind of stand them up and get another PT or PTA to check that catheter for you. Because the higher you can get them, the more you can get them upright, the greater you can decrease their blood pressure. And if we can decrease the blood pressure as much as possible, that can prevent them from stroking. So if I beat nothing else into you from this spinal cord lecture, autonomic dysreflexia, know your symptoms, stand them up, check the catheter. I had 22 questions on my boards about autonomic dysreflexia. 22. Out of 400 or out of 200, 10% of my boards was on autonomic dysreflexia. Thank God, again, my Ann, who was our PTA that trained us on neuro, literally beat this into us and said, yeah, they may get lightheaded, and that's okay. They may pass out on you, Matthew. Absolutely. That's why you've got to have that gate on. You got to be protective, right? They may pass out on you. Not likely as much because you got to remember that blood pressure is pretty high and it takes a pretty significant drop. So most of the times going from supine to sit, and don't quote me on this, these are not hard numbers, but going from supine to sit is about a 10 millimeter mercury drop. Going from sit to stand is about a 20 millimeter mercury drop. So a 20 millimeter of mercury is not likely to get them to pass out or get lightheaded. unless they've already got low blood pressure, right? If you've got somebody that's already low, then yeah, that can do it. But it's possible. I'm not saying it's not. They could get a little bit lightheaded, a little bit dizzy, especially if they've been laying down for a long time. So guard and protect. Autonomic dysreflexia, stand them up, check the catheter. Autonomic dysreflexia, stand them up, check the catheter. All right, let's take a 10-minute break here because I've given you guys autonomic dysreflexia at this point. The only thing else I wanted to mention on this, because I want to talk about this. I bet at least a few of you have gotten symptoms of autonomic dysreflexia. Have any of you ever driven long trips and done the, I'm not going to pee until I get to the next gas stop? Right? And you're starting to drive down the road and all of a sudden you start sweating and you start getting uncomfortable and you start shifting in your seat. Right? Do you ever get that feeling like that? And maybe you start getting a little bit of shivers. That's really autonomic dysreflexia. Right? That's how you can tell a kid's got to go, right? The kid does the pee-pee dance. Really what that is that's a little bit of autonomic dysreflexia. So that was what I wanted to add to that kind of lecture, that kind of thing. Let me pause the recording. Okay, so we're going to finish off this stuff here. So what are patients going to look like that have spinal cord injuries? Well, they're often going to have really bad postural orthostatic hypotension. Why are they going to have that? Well, because after the spinal cord injury, most of these patients are going to spend a prolonged period in the supine position or in the prone position if you're in a good hospital that rotates them. They're going to have impaired temperature control. Almost every patient has that. Respiratory problem is going to happen, especially the longer they spend in a supine position, where they'll go into respiratory acidosis and their blood will actually become acidic. And we know that in order to maintain homeostasis, our blood has to stay a certain pH or problems start happening. So this can be very bad for this to happen. They'll often have bowel and bladder dysfunction and sexual dysfunction. Now, let's talk about sexual dysfunction here real quick. Who is most likely to have more sexual dysfunction, men or women? All right, Michelle's like, men. She's right, though. She is right. Why are men more likely to have sexual dysfunction than women? It's good. You're right. You're right to answer, but this is because you've got to think about it from a perspective of procreation. Women's sexual function is hormonal based. And your hormones are controlled where? Primarily. Your hormones are controlled in your brain, right? Not at the spinal cord. Men's sexual function is primarily muscular in nature, right? We can giggle and kind of chuckle about this all we want, but it's not only talking about getting an erection, stuff like that, but even maintaining the correct temperature to maintain sperm is muscular in nature. Right? Men's testes rise and fall depending upon the temperature of the room in order to maintain normal homeostasis in the testes so that they can maintain a proper sperm count. Right? So when you lose that, sperm count goes down. That means it makes men less fertile. Right? But a woman, ovulating and having, and having their menstrual cycle and stuff like that is all regulated by the brain and the hormones, right? And how many eggs you were created with, or you created when you were a child and you developed all your ova, right? That is just the way it is until you go through menopause. So this can be really, really frustrating, especially for women, because you got to think about that. Just because you have a spinal cord injury does not mean your menses is going to stop, right? And that can be honestly really, I've had women are like, can this just stop, please? I've got my nothing below my ribs works. Why do I still have to go through this torture? Right? So, it is possible for women to have a baby, even though they have a spinal cord injury. And this actually happened in Phoenix a few years ago. I don't know if you guys read this story, but there was a 15-year-old girl who had a spinal cord injury that was in a nursing home in Phoenix. And she was abused by one of the caregivers in the nursing home and got pregnant. Right? And well, you know, the guy that honestly, yeah, she was on a vent too. You're exactly correct. Right? And the guy who did it, you know, one of the things he said is, well, I didn't think she could get pregnant. Well, that's not exactly a reason to do what you did. Right? But that's beside the point. Hey, it was a Law and Order episode too, wasn't it, Erica? Now that you mention it, it was an SVU episode. I didn't think about that, but you're right. There's a Law and Order. If there's not a Law and Order episode for it, there's probably an NCIS episode for it. And if there's not an NCIS episode, there's probably a Frasier episode for it. But yeah, so men and women are very different in their sexual dysfunction with spinal cord injuries. Now, women will have a period immediately after the spinal cord injury where they will become infertile. And that's just a reaction to the brain from that spinal cord swelling, right? But then eventually everything returns to normal. Now, here's the thing with this though, because the next question, and I've gotten asked this before, is what about gratification from sexual copulation? Well, if you have no sensation, you're not going to have gratification, right? Does that make sense? I don't know how else to say it that isn't going to come off completely creepy that I say it. If you have no sensation, you're not going to have that. So indirect impairments, these would be secondary or sequelae impairments, right? Respiratory complications. Dr. Johnson says it's no. Yeah, sure he does. This guy, that conversation would have been great for him. I would have actually loved to have been a little fly on the wall. Anyway, respiratory complications, most common cause of death. Most patients that have spinal cord injuries are going to die from pneumonia. That's pretty much the way they're going to die. Or pressure injuries. I got to change that. I keep forgetting to change that one to pressure injuries. We don't call them pressure ulcers anymore. We don't call them decubitus ulcers anymore. They are pressure injuries. Why we call them that is because ulceration is a natural process. Pressure injury means we caused it, which is what truly it is, right? Ulceration means that it just happened. No, we caused them to have pressure injuries. DVTs, contractures, heterotopic or ectopic ossification we talked about. What's renal calculi? Renal calculi. They're doing math in the kidneys, right? Kidney stones. Good. Thank you, Anthony. Yeah, so kidney stones are real common in patients with spinal cord injuries. And if you have never experienced a kidney stone, I pray to the God that I don't worship that you never have to experience a kidney stone. Because from what I understood and from when I had it, it's the second only to giving birth in pain. And I don't know about giving birth, but holy good Lord, that was painful. Right? Now, the good news is if you have a spinal cord injury, the likelihood of them feeling the pain is pretty low. Or you could have the opposite. It could be hyperpathic and be super painful. So all kinds of pain, stuff like that. Be careful when asking pain from a spinal cord injury patient. Be like, you know, do you have any pain in your legs? No, I can't feel anything in my legs. Right? So be careful when asking about, do you have any pain today? Don't be specific. And how about we get up and walk? I have a spinal cord injury. All right. Potential recovery is directly related to the extent of damage and or its roots of the spinal cord. So the three primary influences: the degree of pathological changes imposed by the trauma, the precaution to prevent further damage during rescue, and the prevention of additional compromise of neural tissue from hypoxia and hypotension during acute management. This is important. This is why if you see a car accident, should you get the patient out of the car, the person out of the car? No. Right? What if you are a healthcare provider and you come across a car accident and you want to help out, what should you do to the person sitting in the car? if it's a really bad accident. Not move them, and stabilize their head and neck if you can. So if that means just getting in and kind of keeping a nice grip on that head and neck until fire and rescue arrives, do it. What is the only time you should move somebody from a car accident? Yeah, risk of fire. Other than that, they should be sitting in the car, right? Now, if it's a little bump and grind accident, of course, everyone's going to get out, exchange information. But I'm talking like serious car accidents here. But even minor car accidents, because Erica can tell you, can cause all kinds of havoc with your body. I just gave her PTSD. I'm sorry, Erica. Yeah, TMJ, exactly. It's all kinds of problems that can happen from it. So but the other thing I'll add to this is not on here. These are the primary influences the book says. But the other side effect, the other thing here is, how soon do they get PT? The sooner they get PT, the better chance that these patients have. So in acute medical phase, we're going to do emergency care. They're going to come in. The first thing we're going to do is stabilize the spine. That's fracture stabilization. We may do immobilization. We may do crutch field tongs. We may do a halo brace, turning frames, pressure relieving beds, stuff like that. So these over here are crutch field tongs. Now, the good part about crutch field tongs is these are little like pressure screws that just squeeze in and squeeze the head. And then you put a weight up here and it distracts the spine that way, right? That's different than the halo here, because the halo with these pins here, guess what they're doing? They are drilled into the skull. And I can tell you from experience, that's not fun. And then they're going to have to wear this vest, and this vest does not come off. So guess what happens to this vest while you're wearing it? It becomes funky because you cannot take it off. And most of the time, this yellow stuff you see here is oftentimes lambskin or wool to provide pressure relief. And if you know nothing else about wool, guess what? It gets sweaty, right? This over here is a striker frame or a turning frame. The patient can be in it and it can literally rotate them like a barbecue roll. And pressure relieving beds, if you've ever seen one of those, they're the beds that the mattress looks kind of like this. And these pockets can fill up and then deflate and then fill up and deflate and fill up and deflate, and it helps relieve pressure. TLSOs, thoracic lumbar orthoses, right? Those are the spinal braces you see a lot of patients that have had surgery in the spine have, right? With PT, we're going to examine their respiratory function, their skin, their sensation, their DTRs, do manual muscle testing, range of motion, do an ASIA assessment, and talk about their functional status. The PT is going to come in and do that. So what are some goals? Well, respiratory management is going to be key. We're going to teach them deep breathing exercises. What is the deep breathing exercises we're going to teach them? The ACB, yeah, there we go, ACBT, active cycler breathing therapy. Now, let's say that I'm in an area that I don't have full diaphragm, or my diaphragm is partially paralyzed from my spinal cord injury. And that may even happen in a patient that's got a lower than a C5. It may just be that they have some damage to that. We're going to teach them glossopharyngeal breathing, or what's called gulping breathing. What that means is, rather than the diaphragm actively contracting, we're going to go, okay, swallow, 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 swallow. And you're not really swallowing. What you're doing is gulping that air in and forcing it down by using the pressure of your mouth. Air shift maneuver is common. An air shift maneuver everyone can do right now. So why don't you just take a breath in, hold it, and while you're holding it, kind of contract your belly and relax your belly. That's causing the air to shift inside your lungs, right? We can do the same thing by doing hand motion, almost doing like a Heimlich. That's helping to expand the areas of the lungs that may be paralyzed. We're going to do respiratory strengthening, go back to the diaphragmatic breathing. We're going to do assisted coughing. So this, again, is very similar to the Heimlich maneuver here, or the abdominal thrust maneuver. I keep calling it Heimlich maneuver. They're going to charge me for it. This is where you're going to get to that third phase of the active cycle of breathing, and you're going to get behind them. And when you need them to cough, you're going to force abdominal thrust. So that helps them get that cough out and potentially clear out their lungs. Mute my watch here. Provide them with abdominal binder support to provide some nice abdominal strengthening, or not strengthening, but support. Stretching is going to be big. We're going to prevent indirect impairments, including those, pressure injuries and stuff like that. Maintain range of motion, whether it's stretching, joint mobilization, or just regular range of motion, we're going to be doing it. We're going to work with whatever muscles are currently active and functional. And then eventually we have to start orienting them to the vertical. That means getting them up and out of bed. And again, just like every other patient, the sooner we can get them up and out of bed, the better the overall outcome is going to be for the patient. So pay attention to that. What is going on here? Hold on. Okay, thank you. Yeah, whatever. Sorry about that. I don't know why I just freaked out like that. So specific functional goals must be established. Reasonable functional expectations must be established. Meaning, if we have a patient who's got a T4 spinal cord injury, we shouldn't be setting gait goals. They're not going to be walking. Everything has to be within reason. We can use a couple different functional outcome measures. We can use the FIM, the wheelchair skills test, the walking index for spinal cord injuries, the SCIFAI. There's all kinds of different devices out there we can use, but we also have to involve the patient in their goals, right? So short-term goals. Short-term goals should be maintain or maximize functional independence. That means we need to work on bed mobility, transfers, and wheelchair mobility. If a patient doesn't have functional legs because they have a spinal cord injury, how are they going to transfer to a wheelchair? What's the method they're going to transfer? A lift potentially, and what other method do we have? We have one more. Slide board. There we go. Good, right? Getting them using that slide board early, the slide board early, and not relying on you to transfer them is key. If they start learning that you're going to transfer them in and out of bed every day, they'll start relying on you, and you don't want that. Integrate your slide board as soon as possible. Progress the skills necessary for homework, community reentry. We may have to instruct personal care attendants or caregivers on how to help patients. I've had to do home health visits where the patient's got a PCA, personal care assistant, that's with him during the daylight hours. And I've had to teach them on how to use specific lifts or how to use a striker frame. So that's another thing we may have to do. We'll do resistive exercises for muscles that remain innervated. So muscles that still work, we can do all kinds of exercises. And one thing here, guys, because I talked to Dr. Reskin about this as well. With regards to exercises, don't get cerebral on yourself and overthink your exercises. If you need an exercise that is training the biceps, your most simple exercise you can do is the manual muscle test for the biceps. You know, if you need to test ankle dorsiflexion, convert the manual muscle test for ankle dorsiflexion into exercises. Don't totally overthink these things because, you know, I've seen people where they get to the boards and the boards are asking for exercises to, you know, open kinetic chain exercises to strengthen for toe flexion. And people just freak out because they're like, the toes, I don't know what to do for the toes. Well, just even having them contract the toes is an open kinetic chain, right? So don't totally freak out when you run out of ideas for exercises. Just go back to the basics, right? Go back to your manual muscle testing book. Go back to your Therex books. Go to that website they gave, the exrx.net. Use wall pulley, sling suspension, group exercises. It's really good to get spinal cord injury patients into group therapy because it makes them feel better that they're not alone. They can see that other people have spinal cord injuries and they're not by themselves. Need to improve postural control if they have it, and substitute balance by using upper body control. If I lack my core control, I may have to use my arms for core control, right? And if I lack core control, that means I also lack proprioception. So that means I need to use my vision to tell me when I am doing motions. So you've got to think about that when you're working with the patient. So ambulation after spinal cord injury. It is rare that you will become a functional ambulator with a spinal cord injury. Why? Well, because you require so much energy to walk, right? So don't always promise your patient that they're going to become functional ambulators. Standing, if they can't get walking, is still beneficial. It improves circulation, helps with skin integrity, helps with bowel and bladder function, and helps with general well-being and sleep. So getting them even into a standing frame or into a tilt table to get them upright is still beneficial if they can't walk. In order to walk, they have to have adequate muscle strength, specifically, at least, if nothing else, at minimum, of the quads and the hamstrings. If they're missing quads and hamstrings, there's no way they're walking. There are all kinds of factors that can restrict it. Severe spasticity, loss of proprioception, pain, presence of secondary complications like pressure injuries, heterotrophic ossifications. Anything like that can prevent the patient from walking. Now, we are getting better. There are all kinds of exoskeletons we're now developing for patients with spinal cord injuries. Specifically, I've seen it specifically with, vets and stuff like that that are recovering from war injuries. But the likelihood of your average patient in the average world getting a full exoskeleton to walk is really slim. Those exosuits that they've got now for patients that are full exoskeletons to help spinal cord injuries walk, they're in the hundreds of thousands of dollars. Your average ordinary person is not going to get that, right? So you have to be aware of that. Focusing on strength training available musculature is important, right? And then talking about orthosis and other things to help support weak or denervated muscles. If your patient has functional quads and hamstrings, but lacks stuff below the knee, we may have to do AFOs, KAFOs, and stuff like that to provide additional support. Scott Craig KAFO is kind of a common one we'll get, and I talked briefly about that. So a KAFO is one that goes all the way down from the knee. So if here's my knee, it's going to block my knee and block my ankle. A Scott Craig KAFO has this little hinge back here. And what that does is when the patient's in standing, that hinge locks and locks the knee. So when they go to sit down, they can reach back here and pull on that hinge, and then their knee can bend and they can sit more normally. RGOs are kind of cool. If you encounter one, I've only ever seen one in a clinic. And RGO is reciprocating gait orthosis. It's typically a THKAFO. So thoracic, hip, knee, ankle, foot orthosis. So it basically is, a full suit that goes around and locks in place. And most of the time putting that on is you're going to spend an hour to an hour and a half just putting the orthosis on. And then what it has is these two handles in the back. And what you can do is you can push forward. It's basically an exoskeleton, you're right. But you can push forward on one side and it will take a step with that. And then you can cause them to reciprocally gait. Is that functional? I mean, not really, but at least it gets them up and working. You saw them? Yeah, Kaylee, they're a piece of work. Just to get them on is a pain. Assistive devices, just like anything else, parallel bars is the safest, then standard walker, then crutches, if at all possible. You don't want to just bring crutches into a patient with a spinal cord injury. That's asking for trouble. So gait strategies, we're going to teach them how to put and take off their orthosis, right? Be aware that a lot of times in the chart, it'll be labeled as donning and doffing, the orthoses. Don means to put on, doff means to take off. I don't know why we have to go like all old English on us, but for some reason they like doing that. Sit to stand activities, trunk balancing, push-ups, turning around, jackknifing where we get them to flex the trunk fully over, ambulation activities in the parallel bars, standing from the wheelchair with crutches, crutch balancing, ambulation activities. All this are important when we're working with them on gait training. But if nothing else, again, we cannot do mobility until we have what? We cannot do mobility until we have stability. Right, good. So they have to be safe and stable before we even think about getting them up and walking. Otherwise, we're asking for a fall. So that means you can do pre-gait activities with these patients. You can sit them at the edge of the bed. You can do quadruped with them, right? You can do jackknifing activities. You can do prone on elbows is a pre-gait activity, right? All of those can come into play to get the patient to the point where maybe someday down the line, they can actually walk and or transfer themselves. So we may do those light gait systems, the partial body weight support, and it's more to talk about sensory walking than it is the normal walking, because you're not going to have a light gait system or a rail gait system in your home. But the good idea is that redevelop some of those neural pathways and helps generate that rethought to gait. Train like you walk. The lower extremities are maximally loaded for weight bearing, minimizing or eliminating loading the upper extremities when we're in gait. The posture, trunk, hip, pelvis, knees, limbs, kinematics are coordinated and specific to the task of walking. Meaning you have to teach the patient again how to walk. They're probably going to lose all normal function of walking. So you have to start with the basics. Right leg out, heel strike, roll through on the foot to your ball of your foot, toe off. And you're going to spend a lot of time doing cueing exactly like that. You may do nothing more than rocking heel to toe on feet for 45 minutes to get them kind of in the idea of walking. Then teach them compensatory strategies for movement. If they're missing their knee flexion, we may have to teach them how to hip hike. We may have to teach them how to circumduct, right? But we have to understand that if we have a possibility of getting that knee function back, we don't want to teach them bad habits. If we know they're never getting dorsiflexion back, well, yeah, we may have to teach them ways to clear the foot. But we can also get FES devices to help out with that. Shoulder pain are common in patients with spinal cord injuries, and it's mainly due to the way they're again. It's great, Keith. Usually due to the positioning, poor seated posture, weight-bearing activities, they're going to be using their shoulders a lot more as a spinal cord injury patient. So that means a lot of them are going to develop shoulder pathologies. So that means we have to make sure we are strengthening the shoulder as much as possible, specifically the rotator cuff, right? We want the stabilization muscles really good and strong. Well, what can we do for shoulder pain? Well, the upper body ergometer is fantastic for shoulder pain. It gets the shoulders moving, right? Wheelchair propulsion can be good. Swimming, and then doing some circuit resistance training for shoulder pain, right? The key thing here with spinal cord injury is they have to understand this is going to be a lifelong pursuit of management, meaning they're going to have to keep up with their training and everything like that for the rest of their natural lives. That includes housing, nutrition, transportation, finance. What if a patient says to you, I'm going to get back to driving, and they're a T4? Can they get back to driving? What do you think? Could a T4 drive again? Did I lose everybody? Absolutely they can. There are hand control cars. There's all kinds of devices that can be added to a car that moves the gas and the brake pedals up to where they can use their arms. There's one that I just saw when I was at the last Next conference, which was almost 2 years ago at this point, that was developing, just like normal driving. Yep. The guy that I would have had come in and talk about this drives a 370Z. So he drives a sports car and has hand controls in it. Right? The one that was, like I said, the stuff I was seeing when I was over at the Next conference, they were actually using basically essentially a modified PlayStation controller to drive a car. It was like basically doing Grand Theft Auto in your car. Except you're not running over people, hopefully. And actually, you mentioned that, and it was funny because when I went to Boston and I got my Uber at Boston International, I get picked up and I get in the car and my Uber driver is paralyzed from the waist down and has all hand controls. Right? Now, initially, think about that for a second. Anybody else that gets in that, they're going to start freaking out a little bit, right? They see a driver driving their car, and to me, I'm just amazed by it. I'm like, this is so cool. I'm getting driven in an Uber by a guy that has no legs, essentially. To me, that was just fantastic. So we can get back to that type of stuff. Now, could that person say, I want to get back to NASCAR driving? Oh, well, maybe not that. And I wouldn't recommend them getting back to impact driving either. I want to go back to being a road rally driver. Well, maybe that's not the best idea. Right? But who knows? Maybe down the line, that might be something. There is a NASCAR driver in the ARCA series, because again, I'm a redneck, so I follow it. There is a kid in the ARCA series that has a spinal cord injury that controls most of his car. So he has, I think he has dorsiflexion, if I remember correctly. So he has a brake with dorsiflexion, but the rest of the car and his controls are in his upper body. Now, I'm going to say this. He's never been competitive in the racing series, but I mean, he's driving in racing with a spinal cord injury. I don't know. It's pretty cool. All right, let's stop share with this. Get over here. What am I looking for here? Hold on one second. I'm trying to find my brain. That's not what I'm looking for. This is what I'm looking for. Share screen. So I put this up in your accessories. That's not what I want to say. In the supplemental information for spinal cord, this is a really, really great kind of one-shot look at what a spinal cord injury looks like. This is from aparalyzed.com. It's a great site. Definitely check it out if you can. But what this does is this allows you to look at what it'll look like. So this would be a good thing to maybe print out and put in your binder. Because it talks about what a person, can everyone see the card? Yeah, okay, good. So say, here's a paraplegic. Here's a tetra. This can be a paraplegic. This can be a tetraplegic, right? So it depends on what it is. But the neat thing about this, it has a little part for each of the cord syndromes. And that can be really useful if you're working a spinal cord patient in the hospital, because now you can look at going, oh, I got a posterior cord. So below the injury level, I've got motor function, but I've got loss of sensory function. Okay, now I know what to expect from that patient. But the other thing it can do is you can go over here and look, and it shows what part of the spinal cords are injured, what part's not injured, right? So with the anterior cord, your posterior aspect is functional, but back here is hurt. But let's say that you've got a patient and you know that they're a T1 neurological level. Well, you can come to this chart and go, oh, well, here's T1. So all of these activities, all these muscles above here, I've got active. So I can do exercise on them. I could do bicep curls. I could do wrist extension exercises. I could do deltoid activities. I can work some diaphragmatic breathing. But I may not work on spreading my fingers, right? Opening your fingers wide because maybe they don't have full function. Definitely probably not working ab exercises because again, they don't have abdominals. Not probably going to work spinal cord activities. So this gives you a quick kind of down and dirty look at this. And this was developed by Rutgers here, obviously. But this is a really useful tool for patients when you're looking at it in the spinal cord and you're in that acute care setting. I think it'd be really beneficial for you guys to keep that kind of handy. Let's look real quick at a patient with a spinal cord injury. Where is my... On here, stop share. I had homework with this. There it is. Let's bring this over here. Let's look at this one case study here real quick, and then we'll call it. All right, can everyone see the Word document I have brought up? Okay, cool. I'm going to make it bigger here. I know it's already kind of small. All right, so we've got a patient, 22-year-old, HWP. What does HWP mean? Does anyone know? Is that a no? Never saw that abbreviation before? HWP means height and weight proportionate. What does that mean about their height and weight? They're not what? They're not obese, right? So you've got an average person. So if you see an HWP, it just means the person's not going to be like me. Just saying. They're a male traumatic complete T7 neurological spinal cord injury. So this guy is a complete spinal cord injury. Does he have bowel and bladder? No. Good. Your patient is due to be discharged to home from the facility within 48 hours. You've been working for this patient since evaluation and know the patient is a moderate assist for upper body movements, maximal assist for any balance activities during trunk instabilities. Your patient is very motivated to get better and wants to get back to his previous life as a junior NASCAR driver. Yeah, Mr. McKeever's a redneck here. He resides alone, but his mother has come in from New York to care for him for 3 weeks. She's 55 years old and in exceptional health. So is this patient going to have at least pretty good, decent health help for the next couple weeks? Yeah. Still, mom doesn't know what she's getting into, but yeah. So you're in the acute care hospital right now. Would home be the best option to discharge this patient? Okay, so I got to know. What would be the best option? If home's not the best, what would be the best option? Yeah, inpatient rehab. Thank you, Erica. Great. Inpatient rehab's probably the best for this patient. Now, that doesn't mean he can't go home and might be successful. He may be. But I would be talking to this patient saying, hey, I'd really recommend that we do a couple weeks of rehab just to get you stronger, right? So if not, we talked about that already, discharge him to that. So now, patient is a T7. What kind of exercises can we have him do between therapy sessions? What kind of stuff could we set him up to do in his room between therapy sessions? What kind of exercises? Okay, upper extremity, give me some. Michelle's right, we get some upper extremity exercises going. What kind of stuff could we have him doing? Bicep curls, good. Pulleys, good. PNF patterns, fantastic. Yeah, now you guys are starting to integrate it. Could I have him do some diaphragmatic breathing and some ACB? Yeah, I probably would, right? I'm going to probably set his hospital bed up like a mini gym. I'm going to have some TheraBand tied down to the foot rails. I'm going to have some TheraBand tied up above the head rails. So he can do stuff where he's pulling down, he's pulling up, and he can get some extension activities going on, right? Because this kid's probably motivated. And the more I give him to do, the more likely he's going to do it. What about sitting at the edge of the bed? Would I give that to him to do when I'm not there? Nope. Right? That's more down in the T10 to T12 range, right? For our core strength. Could he sit up outside of bed? Could we get him up in a chair and have him sitting up? Yeah, we could. I would suggest one of those reclining chairs, because if you put him in an upright chair that's at 90 at that high Fowler's position, he's probably going to droop forward. But if you have him slightly reclined, yeah, we're probably not going to do abdominal bracing, right? Because abdominal bracing, so think about your rectus abdominis and your TRA and your internals and your external obliques. Those are going to be a little bit lower. You may get some, now don't get me wrong, he's going to have some rectus, right? He's going to have the upper levels of rectus, but he's not going to have a lot that's going to provide him with balance. We may work on it when we're working with him, trying to get him to do it, Dylan, but we're not going to give that between therapy sessions, because that's going to frustrate him. And every exercise that we do, give him to do between sessions that frustrates him is less exercises he's going to do. So we need to come in and be kind of that cheerleader for this patient. What kind of transfers are we going to do with this patient? What do you think? Bed chair, good. Can we do a pivot? We could do a squat pivot, but would that be functional? Right? No. So what kind of transfer are we going to do? Mentioned a little bit ago. Slide board. Yeah. He's got most of his upper he's got pretty much all of his upper extremities. Teach him to slide board transfer. Right? And literally day one, I'm doing slide board transfers with this guy because I want him to become as functional as possible. Okay. So what kind of wheelchair? Do we want a manual wheelchair? Do we want an electric wheelchair? Do we want a sip and puff wheelchair? What kind of wheelchair are we going to get? Yeah, we're going to get him a manual. He's going to want an electronic probably because it's easier. We're going to get him a manual because he's got upper extremities, right? You're going to push yourself, buddy. So what kind of parts might we order for the wheelchair or suggest with the wheelchair? I know this is, okay, cushion, good. You're thinking ahead, right? Especially one of those pressure relieving like Roho cushions or something to that effect. Maybe one of those posterior tilt cushions that'll kind of sit him back so he doesn't slide out. So we got a cushion. Yeah, belts. Good, right? Upper extremity kind of harnessy belts to keep him upright. What kind of leg rests might we order? Do we want fixed leg rests or do we want removables? Okay, good. Removables probably. What about arm rests? Do we want them to be removable too? Absolutely. If we're doing a slide board, we got to get them either removables or the swingaways. And the swingaways are like my armrest here on my chair where I can kind of pop them up and now they're out of my way. Now I can slide. Right? So any of those are kind of fair game. He's pretty healthy. Do we want a lightweight wheelchair? Maybe if he's talking about getting back to driving, we may want a lightweight wheelchair because he's going to have to move that chair in and out of his car. Right? And those, the standard wheelchairs like you guys messed with are way too heavy for one person that's got a spinal cord injury to lift in and out of their car. Let's think about it. Would we do lower extremity exercises with this patient? So Ken asked a good question. Would we do lower extremity exercises? If he's a complete, no, because he has nothing in his legs. If he's a complete, he has nothing in his legs, especially, at T7, he's done. his legs are gone. Now, does that mean they won't come back later? No, we can't predict what'll happen, right? But for now, his legs are done for us. Okay, so what kind of home modifications might we need to make? Ramps, good. We got to get him in first. Good. We got to have a ramp to get in the house. What else? Hold on here 1 second. Chairlifts, good. Move furniture, good. What about counters? Do we have to do anything? Make sure what might we want to put around the counter edges? Yeah, the bumpers like we have for kids, exactly, because he's now at a different level and he's probably going to run into them quite a bit until he gets adjusted to it. What about, so we got ramps. What about maybe to get in and out of bed? Might we get a lift for that? Yeah, we might get a lift for him, right? All right. Give me 5 muscles that the patient's lost. Give me 5 muscles the patient's lost because he's a T7. Hamstrings are gone. Good. Quads are gone. Good. Tibs. Good. Yeah, your fibs and your glutes. There we go. They're all gone. So we'd have to use other muscle groups to substitute for them. So we're going to need his arms to move his legs, right? We're going to need his, yeah, he's going to lose most of his obliques. He may have the upper fibers of the obliques, but not much of them. He's going to have to use his arms to control his trunk, right? He's going to have to use his eye muscles to help him with proprioception. Does that make sense? What kind of warning signs are you looking for, physiological or psychological, that you might want to be aware of? Dizziness, good. Depression, pain. What about new muscle loss? That'd be another one, right? Suddenly now he loses more of his core. Or something, now he's got loss of a finger. Those are the things that are going to be warning signs that we're watching for this patient. Your patient states that within 2 months of discharge, he'll be walking again and ready to be back track side. How would you respond to this? What would you say? Yeah, that's it. Good. Great thought. I like your enthusiasm. Let's focus on today and tomorrow and worry about 2 months from now, 2 months from now. Right? Does that make sense, guys? You know, I'm not going to crush his enthusiasm. Or I'm not going to say, no, you're not going to be there. But I need to temper it. Because if I say, yeah, I agree with you, and then 2 months from now he's not, who's he going to blame? Yeah, he's going to blame us, right? So be aware of that. Would it be realistic to believe he'll ever drive a race car again? At a T7, what do you think? Probably not. Would it be realistic for him to drive again? Maybe drive again. But it's unlikely he's going to drive a race car again. Now, let's change it. Now I am an L1 spinal cord injury. Would that be more realistic? Yeah, right, because now I've got full trunk control. You see how that changes? Something simple as that can change the way this patient looks. And now at discharge, this is a fun question because I've had this. Patient states, I want to really stay in contact with you and maybe see you on a more social basis. Can you give me your Facebook or your Twitter? So again, it's like, nope, not happening. Okay, maybe it's 6 months. Good. I mean, if you really want to be active with the patient, sure, go ahead, right? Now, here's where it can come into play. I do keep a professional Twitter and a personal Twitter. So that if they want to contact me on my, I may give them my professional Twitter if they want to reach out to me or something like that, but I never give my Facebook out. Never. It's just asking for problems. Right? You don't have to give anything. And a safe thing to say here is I don't use social media. Now, what happens if you're sitting at home and all of a sudden you get a friend request from a patient? Because it'll happen. What do you think? Ignore, it's a good way of putting it, right? Yeah, I tend to ignore them. I don't decline them because decline can be kind of considered rude, right? I just ignore it and let it sit there. It's not gonna harm me to sit there. Like if you guys right now were to find me and friend request me on Facebook, I'm not going to accept it because you're not considered a peer of me right now. You're considered my students. Now, maybe after you guys graduate, sure, I might accept it. And I have accepted a few of the people that have requested me, mainly because they wanted to keep in touch with me for other stuff outside of here, like this, with they're, really into spinal cord injury patients or traumatic brain injuries. But yeah, just let it sit there. What if he's talking about more of a romantic basis here? Hey, I'd like to, can we go out to dinner maybe once I'm out of here? What do you think? How do you respond to that? How do you respond without being rude? Okay, that works. Kelly's like, I'm married. I'm taken works really well, right? Or what you just, my easy way of saying it is my facility doesn't allow me to socialize with my patients. I appreciate it. Thank you very much. But unfortunately, you're ugly and poor. Yeah. Yeah, you're going to be in a wheelchair. I don't want to socialize with you. Don't say that. Right? But I usually say my facility doesn't allow me to socialize with my patients. I really appreciate the offer, but unfortunately, I have to maintain what my company says. Right? Throw it back on your company. He's not going to go check with your boss to see if he can socialize with you. Right? Because his boss is probably going to say the same thing. I'm a terrible person. You don't want to date me. I am really bad with flatulence. You definitely don't want to date me. Right? The only reason I bring this up because this is going to happen to some of you guys. All right, let's stop sharing here. Bring this over to the middle for right now. So how was that? Spinal cord injury, rough, right? Spinal cord injuries can be fun. Yeah, rewatch for sure. Go back through it. Any questions about spinal cord injuries? I'm going to take that as a no, because no one's responding. I'm going to stop recording.